How are y'all doing?
Pretty good, Shannon. How are you?
And I won't refer to you as someone on the other side of the aisle. I got enough of that, listening to the Michael Cohen stuff.
Oh.
I will be there.
Oh, you're lovely.
That's for actual business.
Good evening, everyone. Today is February 27th, 2019, and it is 5:31. I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business is citizen communications. And Mr. Burton, Central Health, he's our only citizen.
Good evening, I'm Ted Burton, Vice President of Communications. I have two quick items to share with you tonight about community outreach and communications. First, there's a flyer on your desk concerning Family Resource Fair this weekend, Saturday, in the Colony Park Manor communities. That's from 10 to 1 at Barbara Jordan Elementary School. Central Health is one of many partners in this resource fair. There'll be about 40 exhibitors, plus community workshops on things like job resources, home repair programs, tax preparation. Shannon Jones will be there. I think you're doing the welcome, if I'm not mistaken.
No, I won't be there, unfortunately.
I'm sorry, okay. Well, I think you've been part of helping make this happen. And then Central Health and Community Care will be having a joint presence there, providing information about health coverage and using our new online platform to help people begin the eligibility process. So that's this Saturday from 10 to 1. And I wanted to briefly mention, last night was a first for Central Health. We hosted our first ever Twitter chat from 7 to 8. The Twitter chat is essentially an organized discussion about a particular topic for the community. Think of it as a panel discussion, but it's on Twitter. Benefits include growing our social media presence, hearing and learning from our constituents, our partners, and our peers, and perhaps most importantly, engaging with and connecting with influencers who serve our patient population. So the topic was the Austin Health Divide. The hashtag was Central Health Chats. Mike Giesland was our moderator, posting several questions throughout the hour. Questions like, who is most at risk to experience unequal health outcomes and why? What are non-medical, social, and economic factors that impact a person's quality of life? How can we make healthy living more accessible for people of all backgrounds? And what are the ways to empower patients to take control of their health outside the doctor's office? Exciting news for us is that we were trending on something called Trends Maps during the hour, which is significant. This is a platform that's international, worldwide, and shows the topics that are trending in particular communities. So we were trending in Austin. That's a big deal. And in 2 days, our hashtag received more than 500,000 impressions. Yes, 500,000 impressions. 47 people or organizations were participating in the chat, posting about 200 times, including our board member, Maram. So thank you for being part of the conversation, and I'm not sure if others were. We appreciate that as well. So it was a first of more to come. I want a special shout out to our multimedia coordinator, Anastasia Mitchell, who was our project manager on this and helped make it happen, and our entire staff who was in the conversation during that hour. So that's all I have. Thanks for your attention.
Thanks, Ted.
Who does?
Can you sign that up there? All right. Thank you, Ted. Agenda items 2 and 8 will not be discussed. Those items are 2, discuss and take appropriate action to authorize the execution of all documents necessary for Central Health to obtain a capital line of credit from J.P. Morgan Chase. Item 8, discuss and take appropriate action on Central Health's owned and or occupied real estate, including the downtown campus and properties located in eastern Travis County. There are 8 remaining agenda items that will be discussed tonight. In order to ensure that we can accomplish all business, I'd like to accept a motion from a board member to limit the time of discussion to 10 minutes for each agenda item.
I move that we limit the time to 10 minutes for discussion on item.
Second.
Okay. So I have a motion on the floor from Member Bell, seconded by Member Greenberg. Any discussion? Yes, sir.
In order to make sure we adhere to it, we need someone to say it's 10 minutes.
Okay. we can,
So Emily will set a timer, and that timer will go off when we've reached 10 minutes of discussion.
Ron?
I just hope that that 10 minutes is distributed equally amongst us.
Sure, well, I'll make sure of that. Just, Dr.
More
Rollins.
important to me is that at some point in time, we would have an evaluation of the agenda items, because determination of an informational item to me is not necessarily maybe worth 10 minutes if it's to confirm our next meeting. But if it was going to be something having to do with Sendero, or maybe even the discussion on our CEO, I think that that would merit a little bit more time, because it does need to be fully discussed. And so at some point in the future, not necessarily today because there's no time, I would like for someone to give weights to our agenda items.
Sure.
Thank you.
The discussion will, the presentation will be limited. Just on
No,
the
I understand
discussion.
that, but I'm talking about for discussion purposes.
I understand.
Thank you.
Understood. Yes, ma'am. Go ahead.
I disagree with, I agree with Cynthia, what she just said.
So I have to have a 2/3 vote, so I'm going to ask for a raise of hands. All in favor of the motion? All right, looks like it passed. The item passed. All right. The next item for discussion is the consent agenda. Note that item C5 will be moved to the regular agenda for the request of a board member. All right, C1, approve the minutes of the following meetings on the Central Health Board of Managers: December 19, 2018, January 30th, 2019, and February 4th, 2019, a special call meeting. C2, receive a report of the January 2019 financial statements for Central Health as presented to the Budget and Finance Committee. C3, receive a report of the January 2019 financial statements for the Community Care Collaborative as presented to the Budget and Finance Committee. And C4, receive the January 2019 investment report and ratify Central Health investments for January 2019.
I so move.
Here a second.
Second.
I have a motion by Member Valdez, seconded by Member Jones. Any discussion? All in favor, say aye.
Aye.
Motion passes. All right. Okay. Okay. So we're going to take agenda item 1 first. Discuss and take appropriate action on the resolution in honor of Gary Lee and Ann Child for their charitable contribution to the Central Health Premium Assistance Program. Would you mind?
I will indeed. So I move the following resolution honoring Gary Lee and Ann Child. Resolution to the Central Health Board of Managers expressing thanks to Mr. Gary Lee Child and, Mrs. Ann Child. Whereas Central Health received a contribution of $25,000 from Mrs. Ann Child in honor of her late husband, Mr. Gary Lee Child. Whereas Mr. Child, a longtime resident of Austin and former IBM employee, was a devoted volunteer and a Hayes County master naturalist. Whereas it was his wish that people enjoy and learn about nature through his efforts at Wild Basin Preserve, Charro Ranch Park, Jacobs Well, Barton Creek Preserve, and Eckert James River Bat Cave. Whereas Mrs. Ann Child directed this contribution to the Central Health Premium Assistance Program, CHAP, to be utilized by Travis County residents with low incomes and significant health concerns to receive comprehensive health care services through Sendero Ideal Care. Whereas this contribution will help others to lead a healthy life and support Central Health's mission to care for those who need it most and improve the health of our community. And now, therefore, let it be resolved that the Central Health Board of Managers expresses its profound thanks and gratitude to Mr. Gary Lee Child and Mrs. Ann Child for the generous contribution. Adopted this day, the 27th of February, 2019, by the Central Health Board of Managers.
if I may,
Please?
we're not probably the
Hang on one
normal demographic needed,
Let me give you my.
intended by
Or,
Sendero.
do you mind coming here? Sorry.
We can hear you. We're not the normal demographic probably intended by Sendero, but you were a lifesaver for my husband with his pre-existing condition and the limited choices we had in Hayes County. He was very nervous before the elections that happened last year, what might happen up in Washington to healthcare in our country. Nervous watching what was happening in the front page of the Austin American-Statesman happening with Sendero. I was very glad to see the last article that I saw was on the good side. And very honored when I sent a letter to Sendero and CEO Wes Durkowski called me up and emailed me directly. That is a really fine response. It is an honor to be able to help the people of this community. I am a lobbyist working to end poverty. We've worked with Sherry Greenberg before, 20-something years ago, probably. We've had Shannon Jones come speak to our group where Eloise and I are working on global poverty, but there is a U.S. poverty group here also. And so what you do is near and dear to all of our hearts. And we definitely appreciate it. And it just made me feel compelled that you helped my husband so much, and then he ended his own life. And that money could have been used for someone else. And hopefully it will help them now. So thank you very much for this opportunity.
Thank you, Ms.
so
Jones.
much.
Thank you. So I have a motion on the floor by Manager Aiken. I need a second.
I'll say.
Seconded by Manager Musaitif. Any discussion? All in favor, say aye.
I would like to say something.
Sure, go ahead.
I want to thank you very much as someone who fought very hard for Sendero to continue its mission and providing services to us, and as one who fought for us to expand it to include MAP, chronically ill, and very fragile MAP members who are much in need of our services through Sendero for a comprehensive continuum of care plan. I want to thank you from the bottom of my heart, and I want you to know that you and your family, including your husband, are in our prayers. And thank you very much. That's all.
Thank you.
Unfortunately, tomorrow is my last day being a Sendero client.
Oh.
As I moved to Tennessee and to the Cross Blue Shield. Thank you for covering me. I think you paid for a flu shot.
Well, that saves lives too.
That's right. That's right.
That and measles.
Thank you.
Any other discussion?
Productive meeting.
Thank you.
All in favor, say aye.
Aye.
Thank you. All right. I go back to C5. Approve the reappointment of Dr. Thomas B. Coopwood to the Board of Directors of Central Texas Community Health Centers doing business as community clinic. Can I hear a motion to approve?
I'd like to move that we reappoint Dr. Coopwood, who's done a great job here on our board, and he's doing a great job with community.
Second.
Okay. All right, so we have Manager Valdez, seconded by Manager Greenberg. Any discussion? Manager Musaitif.
Oh, thank you, Chair. My question is nothing personal to Dr. Coopwood. I've only heard great things about him and about the work he has done. The reason why I asked for this item to be pulled, I would like to know the process that we adopt for reappointing individuals. What do we have in place? So that's really, it's more of a process, what do we do, and knowing, and how many individuals does Central Health also appoint to other boards as well?
Sure. I think
And term
council,
limits as well.
council has that answer for us, or some of those answers.
Thank you.
So in your packet tonight, and for those of you who have packets in the audience, behind agenda item C5 is a page of the agreement between Central Health and Community Care. And the page that you have describes the board of directors of Community Care. And I would call your attention to Roman numeral 5. And what that provision states is that you, as the Central Health Board, have the ability to submit 2 individuals to serve as board members on Community Care's board. And so Dr. Coopwood is one of our 2 appointments to the Community Care Board. Now, Community Care has the opportunity to provide us with a list of individuals that they believe would fit the description of a good board member, but they can never refuse to accept anyone that is provided by Central Health as long as they meet the criteria set forth here on this page. So that's the process. Central Health has 2 board appointments to Community Care's board.
So in the future, would we be able to reevaluate individuals?
Well, it's time for a reappointment, isn't it, Mike?
Well, to make sure I understand the question, you're saying as a board, for example, in a board meeting, not individually read a bio or whatever, but as a board,
Yeah,
evaluate
like for instance,
individuals?
some of us are new, we don't know all the individuals who are representing Central Health and board appointments. I think it's also an opportunity for us to know who we appoint, and also just, I think perhaps a visit from that individual coming as
Yes, so
reappointments approaches.
I
So
would
that's
say,
really,
that's the prerogative of the board, should it choose to engage in a process like what you've just described. You can certainly do that, it would just have to be posted as an agenda item. And then you need to decide which committee do you run it through, or do you take it up as the board as a whole?
Manager Bell?
Yeah, I just sort of wanted to add on to what Mike said. Since I've been here, those items have been on the consent agenda. They've never really gone through a committee.
Right.
Nobody has had any insight or input into that. It just gets put on the consent agenda. If there's a question, it gets pulled off. And so maybe having some discussion about who we're appointing to what boards, and having a nomination process that we look through, a committee doing that, not the whole board. I think that's too much. I think that would be appropriate. That's just my thoughts.
I agree with that. I think that having a committee do it, I wouldn't think that we need to do this as a committee of the whole, but having a committee that can take the broad view, look at everything that we appoint to, and come up with a process would be the way to go forward.
Manager Valdez?
I know that when a different appointment came up, maybe about 2 years ago, I think it was actually to the Sendero Board. It was, the point that I brought up is whether or not the Sendero Board or any other board, if one of the things that we could look at was whether or not it was reflective of our community and the people that we serve, so that it would be balanced and reflective, because that doesn't always happen. And there are sometimes what appear to be legacy appointments, and, you know, if there is, if we are trying to model for other organizations that we would like to be representative, or that we want them to be representative, as we talk about being reflective of our community in light of all the changing demographics, I think that's something that we should take into consideration as a discussion.
If I may,
Yeah.
Council, if I may bring Jason up to the mic, so he can give us, enlighten us on how many board members are from the community and how many are consumers, and
Sure, I think
They're
Council-
required as a
Sorry.
citizen.
I'm not part of this item.
It's fine for Jason to explain. I know that there are specific requirements for the boards of FQHCs
That's
to
right.
represent the community.
Right.
51%.
But what I wanted to point out to you, Manager Valadez, is under Roman numeral 2 of the page, there's a description of the types of things that are
Right.
considered when appointing board members. So that may answer some of your questions, and if it doesn't, then Jason's here to answer any others.
Thank you.
Evening. So, do you want me just to generally describe what our board composition looks like currently?
Is that on your website?
Yeah. Why don't we, I'm a little, Mr. Chairman?
Sure, sure.
I'm a little confused. Are we, I thought that we were going to move forward with the nomination of the individual who's before us. And then our discussion is that we're going to devise a process for the future.
Correct.
So I don't know that we need to go through this.
We're only posted, if I
Now.
may.
Yeah, we're not posted
We're
for
only
this.
posted for
The nomination.
the nomination.
Exactly,
document.
that's my point. I don't
Not
think,
The nomination and the appointment, yeah.
right, so we probably need to move away from this.
Thank you, Jason.
But we say,
Deal with the,
Good job.
yeah, thank you, excellent. Deal
Did a
with
great
the,
job.
yes,
Hey,
go
Jason.
team. Deal with the appointment before us,
That's right.
and then we'll have an agenda item in the future to have this committee for
Correct.
future appointments. How's that?
So do we need to end discussion and move
Yes.
forward?
I move the question.
That's right.
Do I need to have a second on the move question or no?
Second.
Yes,
You can vote.
that's the
Yes.
seconded.
Done.
Now we need to
Third
vote.
vote.
Okay.
All in favor to
Aye.
end the discussion? Okay, all right.
Dr. C.
Now we have to vote on,
Now we're going to vote on C5, approve the appointment of Thomas B. Cooperwood to the Board of Directors of Central Health Community Health Centers and Being Business as Community Care Clinic. We made a vote.
Yeah,
We
we're
already
just voting on
We're just
that.
voting. So, all in favor, say aye.
Aye.
All right. Thank y'all. Agenda item 3, receive and discuss an update on the 86th Texas Legislative Session related to ad valorem taxation legislation. Mr. Cano and Ms. Owens, thank you for coming.
Good evening.
Thanks.
Lisa.
I'll start off. I've got the easy part. So, Jeff Knoble and Lisa Owens, we're going to do a quick presentation on some of the events going on related to the legislature session, specifically Senate Bill 2 and House Bill 2. There was a request at our Budget Finance Committee meeting to look at some of the financial impacts of that. And then I will state real quickly, I did a presentation which is mainly included in here to a joint subcommittee last Friday. The joint subcommittee is made up of representatives of the city, the county, and AISD. So all the taxing jurisdictions were asked to come do a quick presentation on impacts of pending legislation and then just some general oversight on the budget process. So with that, I'm going to turn the presentation over to Lisa.
Great, thank you. So I'm just going to walk through a few slides. We prepared a memo that was in your budget and finance packet last week, and many of the details are just highlighted here. As many of you are aware, this does apply to all taxing units greater than 15 million, which includes us, and those under 15 million can opt in. But what it essentially does is reduces the rollback rate, which is the rate that triggers an election or a general election, from 8% to 2.5% over the effective rate. And so there's a little bit more information there, but if that rollback rate was triggered, there would be an election that would need to be held by those entities. It also changes some of the terminology, I think, to be more clear as to what is effective rate and what is rollback rate. I included that information there. And then there's also some tax rate process and appraisal processes. But as I understand it, Travis Central Appraisal District is already very much ahead in these areas. And so there would probably be minimal impact here. We're really doing a lot of great work together. So quickly, I'll just highlight our current tax rate, which you approved last year, which is 10.5221 cents per $100 of valuation. It does include just a very small debt service rate. We have less than $10 million in debt in that debt service rate. And it also includes 10.45 cents
of maintenance and operations. As we always like to highlight, we do have the 20% homestead exemption, which is the maximum allowable by law at this time. And then last year, we did increase our exemption for over 65 and disabled to $85,500 from $80,000. So we updated this chart that you've seen a lot in the budget process to just include a comparative of the 6% over effective, which was what it was approved, which the average taxable homestead value is, last year was approximately $326,000. And that tax bill would be about $344 to the taxpayer. The difference, had we been established a tax rate at 2.5% over effective, would have been $333, a difference of about $11 to the taxpayer. And as I believe we talked about at Budget and Finance, just that impact to Central Health overall would have been about $5.8 million in our current year budget.
If I can add just quickly, on the proposed legislation, the rate of increase that is being proposed, it's on the maintenance and operations side. So remember that we have maintenance and operations and debt service that combine the rate. This is about the maintenance and operations side, so the 10.4495 cents that you see.
So,
Sure.
yes, Mr. Chairman, just to make sure that that's clear, so this is on the, what I would call the operating
Yes.
budget portion, our day-to-day operating budget that we typically deal with. We have some outstanding COs, certificates of obligation, that were for a building that we've already built.
Right.
And in the future, an option for perhaps other buildings that we could have under construction would be to use some type of debt instrument, including certificates of obligation, and that would not be affected by this because that is on the debt service portion of our tax rate that we can only use for debt, correct?
That's correct.
So this actually was compiled by the City of Austin. We were at the Joint Subcommittee last week, as Jeff mentioned, but it highlights some really great information, and we've shown you models like this before. This is for an average taxpayer who would live in these jurisdictions, and what the change would be between FY18 and FY19 for a homeowner with, again, a median valued home of approximately $332,000 in FY 2019. And what was added to this that we've not ever shown in our presentations, which is really helpful, is one of the issues facing legislation is the tax on the school finance. And so what we've done is highlighted the portion of the AISD tax that the local taxpayer pays that actually is a part of recapture, as opposed to the portion that stays, is retained by the district here. And so, again, I think we've traditionally shown that Central Health is at about 4.3% of the total bill, with the most significant portion being the AISD school district tax, and that, again, just highlighting that recapture component, which I think is very important. So again, as you've seen this, and we shared this last week, was that just last week?
Yeah. Like how time flies.
I know. But this is our sources and uses and our total reserves, our 5-year forecast, and we trued it up with the actual ending balance as well as the approved budget. And it does show that our reserves do begin to increase with our days of cash increasing, but that our trend of sources being less than uses in FY23 and 24, which will draw on the reserves, will need to be addressed as we move forward, so that we can straighten out those lines and have the sources and uses on a more equal basis. And again, Jeff, go ahead.
Yeah, so to be clear, in our budget process and I know it's hard to believe we're going to talk about fiscal year 20, but this is not the forecast for fiscal year 20. This is simply taking data that we had for fiscal year 19 And as Lisa mentioned, we've trued up a couple of numbers related around fiscal year 18 and 19, just as a tool to use. But we will have a complete 5-year forecast that we will completely work through again. So just to be clear, I just wanted to make sure everyone understood we're just simply updating what we used last year as a tool to begin the beginning, so to speak.
Okay, and last, we have a slide that shows you kind of on a more long-term basis the impact of the legislation, the potential legislation, and that again takes FY19 and even FY20 at a 6% over effective. I believe this, if it were enacted, would go into effect in FY21. But it shows that if we were able to set the tax rate at the rollback rate of 8% over effective right now, which we have not done in several years, that is the purple line that is showing the revenue to the organization, and then the bottom line, the 2.5%, is shown in the green. And what we have traditionally forecasted and what we forecasted, as Jeff said last year, we've kept that same methodology of 6% for 2 years, and then returning to our average has been about 4.5% over effective. And that trend line is in the middle to show you kind of a more realistic view of what could happen. The differences in those show is that if the rollback was moved to 2.5% from 8%, the maximum, the difference between those two is about $205 million over the 5 years. Again, with the FY21 through 25 being at 8%, versus the FY21 through 25 being at 2.5%. And that if it was at 4.5%, that difference is about $75 million in tax revenue. And last, we just added a small chart that was in the memo that we provided, which is the current year estimated impact. So again, this year, FY19, the 6% over effective tax rate did generate about $10 million in tax revenue on previously assessed values year over year. And that if that had been set at the 2.5% over effective, it would have been about $4.2 million for a difference of $5.8 million.
So that concludes our presentation, and we'll be happy to answer any questions that anyone may have regarding.
Thank you, Jeff. Thank you, Lisa. Board, questions? Mr. Jones?
No, I mean, the only thing I was going to say is that we're just going to have to stay tuned because we know that a bill came out of the Senate committee, but it has not come to the floor of the Senate. And in the House, discussions are underway with the 2.5% in the House being taken as a starting point. We will see where we end up. Reading the tea leaves looks like something will pass, but we don't know the amount yet. I don't think it's going to be 2.5%. I don't think it's going to be 8%. Who knows? Could be 4 or 5. I don't know, but. So I think all I can say at this point is thank you for bringing this information to us. The session will be concluding in tandem with our budgeting ramping up. When do we typically get the 5-year forecast?
Usually in the April-May.
April-May, which is session ends May 27th. So. We may not know at the time that we're doing the 5-year forecast. We'll just have to do different scenarios. Hopefully we will know May 27th and we will not have any special sessions.
Mr. Jones?
Yeah, I was just wondering, and I don't know if I've asked this before, have the board of managers from the various healthcare districts around the state ever come together or a conference call to discuss some of these financial impacts it has among our colleagues across the state?
Yes, We're a member of the Teaching Hospitals of Texas, which are most of the major hospital districts in Texas. And they have actually been testifying on behalf of this item, talking about the impact that it would have to the hospital districts as it relates to tax caps and providing safety net healthcare to their populations.
Okay, well, that's good to hear. Separate and apart from that, though, are there dialogues, I don't know, Mike, if you've talked to your colleagues in the other districts about strategies or challenges we face in the various districts?
Because it's going to affect each different district differently, obviously, but in terms of the strategy, it's fluid right now because the bill has gone from being this is a done deal to, oh, this is just a starting point. And because we're different than other hospital districts, our strategy may at some point later on down the line be slightly different from what another hospital district that has a hospital that it funds would do. So that's, in terms of having those conversations through THOT, that's our channel right now. That's how we do that.
Well, I wasn't trying to so much focus on this as much because I get that part. I'm just saying outside of the fiscal or the budgetary process, do we talk about some of the challenges we face with Harris County, Dallas?
All of that's through THOT.
So so that covers all of the healthcare hospital districts in Texas?
Know that it covers all of them, but
Yeah, it covers the major hospital districts. There may be a few smaller ones in Texas, but it covers, there's 6, there's El Paso, Harris, Dallas, Fort Worth, and Bear. Nueces isn't a member, but we periodically talk to Nueces also.
Okay, all right, then I just thought that there was more of an opportunity for us to get together, maybe on an annual basis to talk independently, but, okay, thanks.
Thank you, Andrew.
I just wanted to thank you for the update. This is one of the things that I was fearful of and said so when we were having the budget discussion before. So I would have liked to have seen the 8% just in case. But anyway, as a suggestion for next year or as we're preparing for our next fiscal year, I love this thing that you did on AISD as a school district, but because we have so many other school districts within our jurisdiction, it would be great if you did a similar one for the other school districts that may not necessarily be incorporated, but just in case, so that they could actually see, as opposed to just taking our Travis County AISD picture to heart. They could actually see for themselves. Thank you, that's all. And thank you.
Any other discussion? Okay, this is an informational item, no action is necessary. All right, agenda item 4. Thank you, Jeff. Thanks, Lisa. Agenda item 4, discuss and take appropriate action on the performance evaluation tool and process for Central Health President and CEO.
Good evening, Susan Latta-Willers, Enterprise Vice President of Human Resources. So if you can turn to pages 84 and 85, when we met in January, you all adopted the tool that's on pages 84 and 85. The ask was for you to take the document home and look at it and provide me with any edits. I did not receive any edits, so it stays as is. I also want to talk about, there was some discussion about the adopted tool being being the tool we used last year in May of 2018. And this was not the tool we used in 2018. If you turn to pages 87 through 90, that is the tool that the board used in May of 2018. Very different from this other tool.
Anything else? Was there anything else?
No, I was just supposed to present this to you. But
Okay.
Mr. Chairman?
Vice Chair?
So, yeah.
So actually, my understanding is, Sherry, you're gonna finish off the presentation.
Yes. So, what we were presented with in January was a tool to use in 2020 because it had incorporated measures to evaluate Mr. Giesland against according to the strategic plan, which makes total sense. However, as I say, that cake won't be baked until May of 2020, so we couldn't use it till May of 2020. We then had a discussion about how it would not be fair to Mr. Giesland to wait basically 2 years to evaluate him, and so that we should do something this May. What happened was we took pieces of that cake we were going to use in 2020, just sliced them off and said, well, we'll use that. And that, in fact, is not, because we had this discussion about using what we used last time, that's not what it is. This, starting on page 87, right, is what we used last year for Mr. Giesland. So I don't know what other members think, but to me, it made sense to go ahead, I would think, and use for May of 2019 what we used last year. We edited it, we blessed it, it's a whole cake here. And then in 2020 to use the whole new tool instead of just for this May pulling some pieces out of that kind of slapdash. So that's what's before us is you can see the pieces we carved off last week, which we somehow, I think, thought that was going to be what we used last year, but it's not. Page 87 is what we used last year.
Manager, was I taking?
Thank you. I agree with you, Sherry. I think that makes complete sense. And also, if I may recommend to the board that we establish a working group in April for us to develop a detailed tool that aligns with our strategic plan and expectation. I believe as a whole, we need to probably, rather than individually working on the tool for 2020, that we...
I think we adopted a tool for 2020
Yes,
last month.
But as I believe it will be more of us together in a working group working on this tool.
So I think clearly we could bring that, since it's for 2020, we adopted it, we could bring it back in the future and have, if we wanted, a subcommittee or a presentation to the board to see
I'm
if
not
we need...
asking for a subcommittee. I think it is more of a special meeting for us to
Yeah,
work on a
I don't think that's on the, I don't think that's on,
evaluation tool.
I don't think that's on the agenda, but certainly that makes sense, and we can look at it in the future, that we adopted it. Clearly, it's a little ways off, and there may need to be some fine tuning, and we can come up with a process for that. I hear what you're saying, it's just not on
But
the
it will be
agenda.
adopted for the next round.
Right, for
But I
2020.
think we need at least to bring it up in
Yes.
the next couple months for us to work on it, to give.
Well, we'll see on the timing. That may be a little soon, the next couple months, because of that's the whole issue, is the strategies that's tied to aren't far enough along. So we may need to wait. I'm sure we can ask
So what is
our
your
expert
recommendation?
here.
So there is a timeline on page,
Yes.
page 86. And so if we get, in May of 2019, you all will evaluate the CEO. And in June of 2019, we will come back to
Right.
approve the new tool. So we will have to figure out a time.
Right.
And we can wait between May, sometime in May to do it, or late April if we
Okay.
need to, so.
I'm
So-
confused.
Okay, I think I understand. After we do the May of 2019 evaluation, then in June of 2019, the schedule here says that we will adopt the new tool. So what we could do is before that and offline, we can discuss how to do it, have some kind of subcommittee or process to make sure that we don't want any other fine tuning to what we adopted in June of 2019, which we already adopted previously, but it will come back before us, and that will be used in June of 2020. So we will come up with some process.
Now till June, that we'll have an opportunity.
We will come up with some process,
Okay,
yes.
sounds good, thank you.
Right, yep.
I'm still confused. Say, Susan, didn't we pass
Yes.
the evaluation tool
We
for,
did.
in January already? Are we asking to tweak it again, or what is the question?
So, yes, so you adopted in January
Right.
the
Yes.
tool that's on pages 84 and 85.
Right.
Yep.
But I wanted to bring the previous tool because there was some discussion that the tool on pages 84 and 85 was what we used last year. And I just wanted to clarify that that is not the same tool.
So we're dealing, if I may, Mr. Chairman, with two issues. One is what we do for May of 2019.
Correct.
Okay? We've adopted two separate tools last month. One was, because we didn't want to wait, out of fairness to Mr. Giesland, 2 years, we carved some pieces out of the tool we adopted for 2020, and said we'd use it for May of 2019. Many of us thinking that that's what we had used last year, and it wasn't. So what our professional did is bring back before us what we used last year. If we want to use that for May of 2019, we would have a motion to use that, right? Then we will, in June, be moving forward with the tool that we adopted in January, right, for 2020. Is that correct?
We would come back and review that, yes.
Yes, we did adopt it, but there's another opportunity for review.
us to review.
And what the member here wants is some subgroup looking at it before it comes back again in June. Did I summarize everything properly? Okay.
I agree with the summary.
Okay.
The only thing I'm confused on, last month, I thought we actually approved just the 2 pages of the tool. And then we were gonna wait and deal with the strategic plan part of the tool that
Did we?
was pulled.
In the minutes.
I don't know, that's what I'm
Yeah,
asking.
so what happened last meeting is the motion was specific to 2 components of the
Right.
larger tool, the professional
That's what I thought.
development and the board relationship competency. And there was a discussion that maybe those parts of the tool were what were used last year, and that's why Ms. Willers brought
Right.
this back to say they're different.
Right.
Exactly.
But did we adopt anything for,
2020?
2020, no.
We did not, there was
okay,
discussion
that's,
about
yeah.
it.
That's why we have to do that in
In
June.
June.
That's correct.
Okay.
I think I did misspeak. Yeah, you're right. That's why we have to do that in June. And what our colleague would like is before we do that in June to have some type of subcommittee, which I think offline we could figure out that or the process. So I would like to make a motion or some, I think I have it somewhere here in front of me, that if we want to use the tool we used last year, which is what we thought we were doing but we didn't, that we have to have a motion to adopt that, right?
First, we have to rescind
Yes.
last month.
First, we have to rescind the pieces we carved off last month. We have to rescind that, so there'll be a motion to that. And then next, there would have to be a motion to use the tool that we used last year.
Very quickly before you do that, I think one of the important things we should do is check with the person being evaluated whether they are prepared for this, because it's very unfair to evaluate somebody on something they didn't know they were going to be evaluated on. So I just want to check with you, Mr. Giesland, if you have a preference of which tool we use, whether one would be a problem given that you didn't know this was coming and it got sprung on you. I want to make sure that you're happy with either, or that if you have a preference, I'd like to hear what that would be.
Thank you. In terms of a preference, no. But I'm prepared to be evaluated under either. But if you go back to last year's tool, that's something that I understand. I don't have any questions on it, and can
Yeah.
certainly provide you with whatever information you need to make your evaluation thorough.
Great, that's what I wanted to hear.
Do you have a question, Jen?
I'm confused, but I think I clear. So what we're saying, if I'm correct, this here we're gonna use as of May 19th.
Correct. And that's what we used last year.
Right. And this here we'll use, we're not gonna use it
We're
all.
done.
No, because it was just some pieces carved off of what we're contemplating use for 2020.
Okay,
So
so
we'll have
we're gonna consider it in the
in
discussion.
June, and
Okay.
we'll have some
Okay.
subcommittee or process to
We'll work on
work
something.
on that before June.
Is the anticipation to incorporate some of this in this when we get, or is that?
Can have that
Possibly,
discussion.
possibly.
Okay.
And that
all
I
right.
think, and Ms. Willers has a complete tool that we can look at.
Okay.
before June
Okay.
for 2020.
Okay, that passes.
Can I make a motion to rescind the previous action?
It is,
Yeah,
yes,
Okay. I move that the motion related to the acceptance of the CEO evaluation tool that was made on January 30th, 2019 be rescinded.
second.
Okay, so we have a motion on the floor by Manager Valdez, seconded by Manager Greenberg. Any discussion? All in favor, say aye.
Aye.
Motion passes. So it's now rescinded. So now we're going to take the second motion. Terry?
Okay, so the second motion is, I believe, right here. I move that the board adopt the performance evaluation tool first presented by staff in December 2017 for use in May 2019.
Second.
We have a motion on the floor by Manager
For
Greenberg.
2020.
No, the one in
Oh,
2017
sorry.
For
Okay.
2019.
for 2019.
I apologize.
We have a motion on the floor by Manager Greenberg, seconded by Manager Valdez. Any discussion? Any questions?
Just one quick question. So we're voting on this?
Correct.
Except this?
Which is what we used last year.
Yeah, okay, I just want to make sure this is. what we're
That's
voting
it.
That's it.
Any other questions? Any discussion? Manager?
Just a suggestion, since we do have our board retreat in April, if we could, each of us as board members, look at this and maybe give us 30 minutes, maybe, an hour, just to discuss the tool so that, because we have so much that we're going to be dealing with this fiscal year, maybe that might be a good use of some of that time.
It's been mentioned, yes.
I'll ask staff to put that as an agenda item for the.
I appreciate that, sir. Move the question.
Any other questions? Any other? Okay. All right, all in favor say aye.
Aye.
All right, motion passes.
Thank
So
you.
we'll be using the tool that we used in December of 2017 for this May. Thank you. Thanks, Susan. All right. Agenda item 5, discuss and take appropriate action on the amendments to the bylaws of Sendero Health Plans, Inc. Holly and Charles.
Well, before you in your packet are the redacted, not redacted, revised, Central Health bylaws. The Central Health Board is responsible for drafting and revising the bylaws of the company that reports to it, which is Sendero. So, the information you have here has gone before the Sendero Board, and we have asked for certain changes. I'm gonna let Holly walk you through those changes. We are not gonna take a vote on this tonight to allow you to take it home, study it, ask questions. You can send me questions, or you can send Holly questions, and we'll get those answers for you. It will come up in the March meeting, and we will take a vote for approval.
Should we send those to the message board or to your personal emails? Would it be better for the message board?
So if you have specific questions about the meaning of an edit, I think it would be appropriate to put those questions on the message board. And then if we feel like it requires attorney-client advice, we won't respond that way. But if it requires no attorney-client advice, then we'll respond via message board.
Yeah, that's what I thought it would better.
Great.
Thanks. Thank you, Mel.
Okay, so what I plan to do tonight is talk about some of the more meaningful changes that were made. There were some changes made that were purely stylistic changes. For example, the prior version of the bylaws used both the word member and the word district to refer to Central Health. And in order to avoid confusion, we chose to use the word member throughout. So anytime you see the word member, that means Central Health. The first substantial edit that was made to Article 2, Section 3. And so the caption of that, if you're more of a caption person, is members' rights. And there was an edit made to subsection N. So I'll give you a second to find that. And what this edit does is it provides some clarity to Central Health about who key personnel are, because Central Health was responsible for entering into employment contracts with Sendero's key personnel. We have defined key personnel here as the Chief Executive Officer, the Chief Operating Officer, the Chief Financial Officer, and the Chief Medical Officer. So those are the 4 individuals who Central Health could enter into employment agreements with. The next major edit would be Article 3, Section 1. The caption is general, and you may also be able to find this easily by the comment off on the right-hand side of the page. And so this was an edit made by Betty DeLargy, who, as you know, is the attorney for Sendero, and she reviewed several other HMO bylaws and felt the addition here of the language following the first line, who may exercise all such powers of the corporation and do all such lawful acts and things that are authorized by applicable law, the certificate of formation, or these bylaws, and are not specifically reserved to Central Health. So that's the language that has been added. It provides a little bit more flexibility for Sendero on what they can do in terms of managing the business and affairs of the corporation. Following Section 1, there was an edit made to Section 3, which is captioned annual meetings. Very much like the Central Health bylaws, there was an actual date listed for the annual meeting. And to provide some flexibility for the Sendero board, we have removed the language that used to be there that said the first Tuesday of October. And now the annual meeting can be held at any time in October, just to ensure we're not violating our bylaws due to scheduling conflicts. You'll also see Section 4. Section 4 is a new section. It does not include any new information. It's just a new section that clearly lays out the duties of the chairperson and the vice chairperson. And they're very similar to the duties of the Central Health chairperson and vice chairperson. Section 5 is a new section called regular meetings. And again, this isn't really new content, it's just a new organization. Section 6, another edit was made in the second sentence to clarify who had the authority to call special meetings. So it is the chairperson or any director or officer of Sendero who the chairperson requests to call a special meeting. Moving to the next edit, Section 10. Yes,
So the only change is adding the authorized?
It is clarifying that the directors or officers must be authorized at the request of the chairperson. So before, there was no clarification that the chairperson had to request those people call the meeting.
Okay, it's just when I'm used to seeing changes, what I see is
Red
a
lines.
line, yeah.
Red
Yeah.
line.
So where we're seeing
And that is a
accepted.
much clearer designation as to what needs to be changed, what language we're looking at that was or wasn't there
We will
before.
make sure that you have red line version, and we can send those to you after this meeting.
I appreciate that.
Moving on to Section 10, vacancies. There really wasn't any substantive edits here, but I wanted to point out that one thing we did do, the former version of the bylaws used the term chairman, and we have changed all references to chairperson and vice chairperson.
Thank you.
We have also made, in terms of vacancy, last sentence here, Cynthia, hopefully it will be easy to follow along. In the event there are 2 simultaneous vacancies that are the chairperson and the vice chairperson, in the past, it was the Central Health Board that had to appoint an acting chairperson, an acting vice chairperson. These bylaws give the authority to Mike to name an acting chairperson, an acting vice chairperson, because it may be a period of time between when Central Health can meet next and when Sendero Board meets next, and you need to have someone who can call a meeting of Sendero. Let's see here. Moving on to Article 4. So Article 4 is captioned officers. There were several changes made to this article. One thing that was done is we've removed the requirement that Sendero have a treasurer. And you can see from the comments here from Betty that there is no requirement for a treasurer under state law. So instead, the officers of the corporation will be, as they have been, the president and chief executive officer, the secretary, who is also now the chief operating officer, it's an automatic, and a chief financial officer replaces the treasurer. All right. Moving to section 5 of that same article, still Article 4, you will see the caption is President and Chief Executive Officer. There is a couple of new sentences at the end. So towards, I would say, maybe the middle of the paragraph, it says, "The President shall also perform all duties incident to the office of President and such other duties as may be prescribed by the Board of Directors from time to time," and here's what's new, comma, "but only if such duties are not reserved to the member," which is Central Health, "and are consistent with the member's responsibility to provide healthcare services to residents of Travis County." There is also another sentence that follows what I just read, and that is new as well. And I think it would be useful if everyone takes the opportunity to read that sentence and think about it before we come back next month to vote on these bylaws.
This particular sentence.
Yes, ma'am. Moving on to Article 7, Section 1. So Article 7 is committees. Section 1 is committees of directors. And what has been done here is to remove several of the actions that the committee could take, that the committee could not take. And the reason those actions were removed was because they were redundant. So there was a laundry list of items that committees could not be charged with doing, but all of those items were actually reserved powers that only Central Health could exercise anyway. Yes, ma'am.
So there's this line in red at the bottom of Article 5 before we get to Article 7. That's not a change? It's just in red for no reason?
No.
Not Article 5, committees, not Article 7.
You went from Section 5 on page 101 down to Article 7 rather, and skipped Article 5, so I'm wondering if that's a change or not.
So there was a non-substantive change there that we could discuss if you'd like, but I am just focusing on the actual substantive changes.
Okay. Well, I don't know the difference between substantive and
Yeah,
non.
so there were some things that were just done because it makes more sense for us to rewrite them another way. It's easier to understand, and those are things I considered non-substantive.
Okay.
And then there are things that we've done that change what the bylaws say, and those are substantive. So looking at, again, Section 1, Article 5, you will see two comments on the right side. And my comment here, which is HG10, indicates that there was text above that had been deleted because all of that text were actually actions that were reserved to the Central Health Board, and it was redundant to list all the things that they couldn't do when it was already clear from the reserve powers that they couldn't do that. Moving on to Article 6. So this is called the liability and indemnity of directors and officers. And I really want to commend Betty because I think Betty did a very good job of making this provision look similar to what Central Health's bylaws state. In the past, Sendero board members and officers were indemnified for any suit whatsoever, regardless of whether they committed a bad act. And so this actually excludes from indemnification and defense any actions that were taken in bad faith, were taken because they were exercising gross negligence, or they were guilty of violations of law. And that will save Sendero and probably Central Health money in the event anything were to happen by a rogue director or officer. Moving on, Article 10, which is called the Standards of Conduct. This is a brand new article. And what this article does is requires the Sendero Board of Directors to adopt a code of standards of conduct. As you know, you all have a code of standards of conduct, and so this just puts the same onus onto the Sendero Board. And it also further explains that conflict of interest policies need to be adopted as part of that code of ethics as well. The policies shall be consistent with any conflict of interest disclosure requirements applicable under federal and state law. But in addition to that, the policies shall, if the board determines advisable and appropriate, and this is the Sendero Board, address conflicts that are not prohibited by law either, if they think that we need to go further than that. And then the last change you will see is actually Article 14. You're really testing my limits on Roman numeral recognition. There's an adoption of restated bylaws. And so in the past, that just said adoption of bylaws. This section now recognizes that if these were to be adopted by the Central Health Board, you would be adopting amended and restated bylaws as of whatever date we consider this in 2019. And that is a pretty exhaustive overlook of what we changed.
You ready for questions, Paul? You ready for questions? Ron?
Mine is really quick clarification. In terms for the CEO, there's nothing that says anything related to his evaluation. So where would that be? Or is that?
There is nothing in the bylaws that speaks to who is responsible for evaluating the president and CEO. However, you will see in next month's meeting an employment agreement between Central Health and the president and CEO. And that employment agreement addresses which body, Sendero or Central Health, is responsible for evaluating the president.
Shouldn't we have that in bylaws?
It is completely up to you if you'd like to have something stipulating who conducts evaluations.
Okay, thank you.
Manager Walters.
I'd like to know whether or not, Dr. Bell, since you're the chair for Sendero, I'd like to know whether or not you all had this discussion with your CEO or officers, or were they at least present while you had this discussion on proposed bylaws changes?
Yes,
Okay, and,
I said that initially, but.
oh, I missed it, I'm sorry. Thank you. And so will we have an opportunity to hear from you as to I guess not necessarily from you, but will we have an opportunity to get the justification?
The justification is that, first of all, the bylaws were difficult to read.
Yes.
And we were confused about a number of items that were in there. So the board actually felt that it was important for them to be reviewed and to make some changes to make sure that we were following our own bylaws.
Well, since we've never seen them, that's why I'm asking, because we've never seen them. This is our first opportunity to look at them. And were there ever previous bylaws? Or is this the one that's been in place all this time?
This is the one that's been in place the entire time.
Okay, so at next month's meeting, when we adopt them,
Yes.
will we have that opportunity to have a discussion about some of these things? Because what I'd like to do, and this is on my own, if nobody else is interested, is I'd like to see, since this is an enterprise, and I'm assuming that these bylaws will then be consistent with what Central Health has in place, or Community Care has in place, or the CCC has in place, so that we know that we are consistent in what is language and what is importance in how we do business and with how they do business, because they're under us. So I want to make sure that there's a consistency and maybe some kind of standardization of language in all the bylaws, so that there is not any one separate or different than the other.
This question would be sort of directed at Mike, because I'm not an expert in this, but these bylaws were developed because we as a member created a corporation. And so, in essence, this corporation is part of our, as she said, our enterprise. I don't necessarily know what our relationship is with community care, which is an FQHC.
Right.
All right?
But CCC,
And CCC, which is a nonprofit.
which we created.
Okay.
Yeah, but they're different.
So I'll let you, if you can address that, fine. If we need to address that at a later date, I'm okay with that.
Well, the agenda item is limited to the Sendero bylaws, and I think Manager Valadez, what you're raising is a larger governance issue
Correct.
at the enterprise level.
That's right.
I think that would need to be noticed and have a discussion set up around that.
Well, then I think that it would be incumbent upon us to at least get, if all the board members are interested in reviewing the bylaws for Central Health and CCC at the very least, to make sure that they're aligned and that they cover the same important issues that we are all looking to protect ourselves from, or to make sure that the entities are fully functional and operating, to the highest standard. I think that would be important for us to have.
Thank you, Manager. Any other questions? Manager Jones?
No, I just want to concur with Member Valadez's comments, but more, I think that from a point of, are there expectations among all the enterprises that are built into the bylaws? Obviously, they're not going to be word for word.
No, that's right.
But are there certain expectations of the enterprise that we have of them all, that they'll be consistent in doing things? I think that's the gist of the question. And I think that what Dr. Bell has said, indicated as well, is that he can't speak particularly from that point as a chair of Sendero. But from the point of view from the board, it seems that that's something perhaps in the future we need to look at, trying to identify what those expectations are across the enterprise of what we want of bylaws from all of the partners that are part of this, I guess is where we're headed. I don't think we can do it by next week.
No,
I mean,
no,
next month.
no.
No, but that's a discussion to be had.
Manager Jones, any other questions?
That's it.
Anyone else?
I hadn't finished, but thank you. And then I would like to know, when we have the discussion about conflicts of interest, I know that that's something that's in here, and since we have, if I'm not mistaken, unless that your board has changed, do you have any Central Health staff that's on the board for Sendero?
Yes.
Okay, I have a problem with that. Just like I have a problem with staff being on the CCC board, unless we can clarify, because that to me is a big conflict, especially as we're enterprise, and we have officers that are covering all the enterprise, and they do look at how the administration, the entity is run, and then they come to us and make presentations on what should be addressed and not be addressed, if there are changes that need to be made or whatever. But regardless, I think that's a conflict or an issue that I think that we really need to talk about.
Posted for that, so I'll ask the
Well,
question.
it's a conflict of interest
So
language here.
let me just point you to, okay, looking at Article 3, Section 12. So this was thought out by the prior drafters of the bylaws when Sendero was first created. And you'll see here in Section 12, little subsection A, that the purpose of Sendero is to provide for the orderly implementation of the authority granted by Central Health's Board of Managers to establish a health maintenance organization to carry out Central Health's responsibilities of providing healthcare services to residents of Central Health and other counties as authorized by the state of Texas. Accordingly, no conflict exists between the interest of Central Health and the interest of Sendero.
Well, I don't know that if you have the same people on the board that are staff under us, that we don't get to evaluate, then we may have some kind of a concern, especially with the fact that this is a separate 501c3, that it is responsible for providing a health insurance plan to our region, not necessarily only Travis County. And sometimes, as we look at what's important to us or what are we dealing with, especially as it may refer to budget and to priorities, that that there may be a difference of opinion that the managers may have, or some of the managers may have, than staff has. And
Manager Rose,
and so I'm just curious, when are we gonna get a chance to talk about that? Because it is governance.
And we're down to less than a minute, 2 minutes.
Okay. So,
So I think my
Manager,
response would
Mr.
be
Giesman.
that this is our chance to look at the bylaws. If you're unhappy with the way this section is written and you'd like to propose alternative language, as everything else is done, it's resolved by a majority of the board. If a majority of the board likes the language as written, that is what will be passed.
Yes, Mr. Giesman.
Council mentioned it, that's all.
I know we're at our 10 minutes. Just really briefly, I'm a little uncomfortable with using our time that way. I know that I'm only one person, but I feel like it's a little Texas legislature style micromanagement on local control of things, and I'd rather be kept out of it, but maybe that's for another day, so just leaving it there.
Okay.
Mr. Chairman, I'm sorry.
Giesman.
Manager Valdez, I understand what you're saying, but boards have conflicts all the time,
sometimes they're called out, sometimes they're not.
sometimes. But I want to take this opportunity, if I may, to publicly thank those staff that are willing to take on this role. It is like the role that you take on at times, most times it's thankless.
That's true.
And it is highly complex, and the fact that they're willing to sign up for this sort of thing, just as you all do, and what I think is in a very ethical and highly ethical way, manage these conflicts, just as you all do. They've gone above and beyond the call of duty, and I need to call that out because nobody else will.
Well, this is not, any commentary on anything other than what the definition of what I think conflict of interest is. This is what we've been told, that's all.
Thank you, Manager Valdez.
Very simple.
All right, it's just an informational item, no action is necessary. We'll look over to Emily, and Emily, do we have food next door? Okay, can we stand down, Mr. Giesman, for about 10 minutes?
The chair's prerogative.
Let's stand down for about 10 minutes.
Yeah, so the appropriate thing to do would be to motion for recess.
So you want to recess or just?
Yeah.
Yes, I move that we recess.
Any discussion, all in favor, say aye.
Aye.
Votes next door. Let's take 10 minutes and come back.
Oh, would this not
Let's come back to order. It's 7:01. We just went for a quick brief recess. Agenda item 6, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the Central Health Board of Managers Strategic Work Plan and operational priorities, B, an assessment of organizational work systems and processes, and C, other personnel matters. Mr. Useman.
Members, in your packet is a brief memo that is the CEO's report. You'll recall from the last report we focused on the strategic work plan and key milestones that are coming up over the rest of the fiscal year. This particular report drills down on the actual work to be done by the board that we've scheduled out as best we can, realizing that these are just key work items. Obviously, there's going to be other approvals that come to you and other board business, but we wanted to capture some of the larger, more salient items. And this tracks either what is in the strategic work plan or as an operational priority for us as an agency, or which is outlined in the budget as being an expenditure priority. There are two matters that I would like to point out. We'll be presenting 2 additional education workshops. We had one workshop on population health that was well received. Following that format or something similar, we'll be presenting a workshop on healthcare financing in April, and tentatively for May, we'll be presenting a healthcare contract workshop. And healthcare finance, I think, speaks for itself. It's a very broad topic and very complicated, but I think it's important just to refresh, how is it that we fund healthcare. And then in May, for the healthcare contract, understanding how contracts are put together for providers, because you hear a lot about value-based care and different contract forms that are different from, fee-for-service, and just understanding how that all works, I think, is essential to being in a healthcare district. So we'll present that to you. That concludes my report. I'm happy to answer any questions.
Any questions? Seeing none, agenda item 6 is just an informational item. No action is required. Agenda item 7, receive and discuss an update from Community Care regarding A, current and future clinic locations, and B, alternative healthcare delivery strategies. Mr. Wallace. And then Jason. Thank you, Larry.
Good evening. Larry Wallace, Chief Administrative Officer, Central Health Enterprise. I'm here to talk to you just before Jason comes with his presentation to provide information on how we plan to move forward with decisions on future services. And our goal is to do a couple of things. First of all, we don't want to create expectations that we cannot meet. And secondly, we want a clear funding strategy on what it is we're doing. And thirdly, the creation of a decision matrix that will really guide us as we move forward into the future in service delivery. And what I want to talk about is the order in which this work will convene. We do plan to leverage the resources in the Central Health Enterprise. That's Central Health, of course, Community Care, the CCC, which has a major role in this work now and going forward. And we would also even see where Sendera fits in the area of coverage. So the enterprise resources will be fully deployed as we move forward. We also intend to fully leverage the Eastern Travis County Healthcare Coalition. As you know, that's a group of providers and partners, over a dozen groups, and we meet on a regular basis to figure out how we can advance healthcare in the community and to do it in a collaborative manner. It begins really with joint planning and that strategy. And every year we go through a strategic planning process. You're a part of that. And so there are no surprises on what's to come over the next 12 months. Once the strategy is developed, along with participation from the board, and I envision it'll be a joint process with community care because they provide the lion's share of our services. And we can, at that time, identify priorities because we can't do everything at once. And again, we want to have a coordinated, effective approach in this way so that we don't disappoint people. The last thing we want to do is make announcements and then we find that we're not in a position to keep our word. And much of our work is done with partners. So moving forward, we need to really zero in on their participation, their commitments, and as we move past strategy, then the next conversation is with the providers. We believe that the providers really should have a major voice in where we go and what we do and how we do it. And again, providers will use data, and also we listen to the community. That is not going away, so none of that changes. Modalities, social determinants, all of that is included in our process. And then we build a business case. We need to understand how we're going to pay for it, who's going to participate in funding, and again, that includes the commitments from the partners. At that point, when we talk to partners, because they have an annual budget cycle, it's important for them, if they're at the table, they make a commitment, they need to go back and make sure they can honor it. So the last thing we need to do is, at the end of the conversation, find that they're not able to step up and commit and do what they committed to. So it's just a more clear process. And then once we get that done, then we talk about real estate and what's needed. And in the area of real estate, that's either new facilities, existing facilities, maybe no facilities at all. There are other modalities that we can include, such as house calls, and you're going to hear a little bit about that, I'm sure, from Jason and his team. But we need to have a clear path on how we fund social determinants of health going forward. So again, our goal is to have a process that is clear, it's coordinated, it's effective. When we say make a commitment, we know that we can stand behind it. We also intend to pull the hospitals into this conversation. So the collaborative that now meet is primarily the outpatient primary care providers. It's everybody that the CCC contracts with. Lone Star Circle of Care, Naturally Community Care, and Peoples is also a part of that, Elbow In. All of those resources are available to us, but we think there should be a greater role for Dale Medical School at this table, as well as Seton Hospital and St. David's. And so we will be expanding that reach, and we just wanted to share that information with you before Jason comes. So Mike, you want to add anything to that?
Yes, sir. I think that covers it.
Okay.
Thank you, sir.
Thank you.
Jason?
And if it's all right, Dr. Zamora, and
Of course,
board
bring
members,
Matt.
I'm going to have Matt Baltazar.
Of course.
Also
Come on up,
joining me
Matt.
up here. So, good evening, Jason Fournier, CEO at Community Care Health Centers.
Good evening, Matt Balthazar, Vice President of Health Center Advancement at Community Care Health Centers.
And so, piggybacking off of what Mr. Wallace had just communicated, it's really a team effort. When we take a look at needs within the community, I think you're very much aware of the fact that we're using a lot of different sources of information. We're using information relative to how the community is changing, how rapidly the community is changing. Last year, we had an opportunity to present to you some of our findings from our 2018 Community Health Needs Assessment. We're also having conversations in the community as well. When we take a look at engagement within our system as a whole, both at the enterprise level as well as in the community at large, we're actually having conversations with multiple stakeholders to make sure that as we're looking at realigning our resources so that they're more proximal to where folks live, that we're making sure that we're getting our services as close to the individuals as we can, giving existing resources. So it's our pleasure this evening to provide an update, and this is really an update on things that are going to be happening in the near term. And so the next slide really just kind of looks at this upcoming, or we're in the middle of 2019, but through the end of 2019, just some of the things that we have on our radar screen, and just flipping to that. So it's really a jigsaw puzzle, right? As we take a look at realigning our resources in order to effectuate change, there's a lot of different things that we're doing. We're evolving our care model. Yvonne Cameron is in the audience. She's our Chief Operating Officer. Again, part of our very, very amazing team that we have within community care that's helping drive change within the services that we're providing to folks and for folks. And one of the things that we're taking a look at then is where do we actually, how do we put the various different pieces together to try to effectuate change, not only in the short term, but long term. And so when we look at that is how best do we use our resources. So down at the bottom, you can see green. These are two initiatives that have just started. They both started in February. Most of these you're probably aware of, certainly the House Calls initiative in Austin's Colony Hornsby Bend, where we have a healthcare team that's actually visiting homes within the Austin Colony Hornsby Bend community. Started last week. It's just up and starting, so we'll look forward to coming back and providing an update on how well received. But that was with our partners here at Central Health, CCC, and others, an attempt to go ahead and get services provided more proximal to folks within that community that has significant needs. And then the other change that happened actually earlier this week, on Monday, Tuesday of this week, is we actually had a move of our complex primary care into another facility. And so I'll talk a little bit more in depth as it relates to that. Then yellow is what's anticipated, and then at the very top in blue is still planning that we anticipate to come to a conclusion sometime later this year. And so I'll return to this slide as we move through. So really going to be covering the yellow portion of this slide, just orientating to you in terms of the site realignments that are happening within March. So a lot going on. As you know, suffice to say, we're keeping our team very busy in terms of moving different puzzle pieces around. So the very first one is a new clinic for us. It's called the Care Coordination Clinic. We received HRSA approval probably about 30 days ago. But this is one that you may have seen in the media in the fall, where with support through Seton Ascension, so Seton Healthcare Family, and other partners, including Echo and Integral Care and other community providers, is really the initial concept was to go ahead and establish a healthcare home or homeless navigation hub using Seton's asset known as Kosmetsky Clinic. So the name's not going to persist. It's going to be the Care Coordination Clinic. But we've actually got that as a homeless hub, and so it includes not only primary care, mental health, substance use services, but also coupled to it is going to be Echo and other social service providers coming in to really provide comprehensive services to the homeless population in South Austin out of that former Kosmetsky Clinic. The other thing we married into that, though, is when we did a deeper dive into our own data relative to complex primary care, which we took over from Seton a little bit over a year ago. It was on February 26th of last year. We had taken over that clinic, which was formerly Seton Total Health. We took a look at the patients that were ongoing and primary care medical home assigned to that site, and we found that 44% of those patients served through complex primary care at the Clinical Education Center, the CEC building on the former BRAC campus, were homeless. So there was some interesting synergy there, and this is really complex care management, a high level. They do advanced procedures. They really go ahead and have individuals have significant, not only chronic disease processes, but also underlying very significant social factors that are impacting their health. We also have bidirectional coverage as it relates to, when I say bidirectional, we have folks who, when they're being discharged from the hospital, if they can't see the primary care physician within 7 days, this is a place they can land and then transition to their medical home. If that medical home is not established, or if they need one that's a higher in intensity, then they land at complex primary care, which is now the Care Coordination. The other bidirectional is if we have someone who's being served from one of our South Austin sites, including Southeast Health and Wellness, William Cannon, and our South Austin Health Center, we also have the ability to then to go ahead if someone needs to be seen in the emergency room, or we think that our primary care is indicating that they need to be seen in an emergency room, we can actually route them to this facility for them to be evaluated before going to the emergency department. So this data is a little bit old, but in July of last year, we had 17 individuals that would have otherwise been referred to the emergency room. Of those, they were all seen in complex primary care, only 4 advanced onto the emergency room. So it just shows you, and there's a lot more data behind that in terms of moving forward. So this was initiated on February 25th. It's just a heads up that this is something that's evolving. It's a 2-year pilot out of that site. And so we'll really be able to evaluate a comprehensive service, including social service providers, eligibility assessment with Central Health folks there, as well as SOAR applications for disability eligibility as well, occurring through SSI or Social Security insurance. Another major shift that's going to happen in March is relative to our Blackstock Family Health Center. So I know we've talked about this before, but I appreciate the opportunity to go ahead and present to you and just where we are in the process. So mid-March, our Blackstock Family Health Center, which includes the Blackstock Family Medicine Residency Program, which is a residency program operated by Seton in conjunction with Dell Medical School as the academic sponsor. As you're aware, the professional office building on the campus of Brackenridge is scheduled to come down, and it's being repurposed, and that's where that site, that location has been for years. And so as part of our planning, we made the decision a little bit over a year, probably summer of 2017, 2018, 17, to go ahead and actually look at what were the options in terms of relocating. One of the things that was considered was would we or would we not relocate to Rosewood, Zaragoza, and a repurposed Rosewood, Zaragoza. We did very, very deep dive in zip code 78702, given some of the changes and other existing assets in East Austin that we have, including our East Austin Health Center, our Sandra Joy Anderson Health Center. It didn't make sense to have another very large practice relocated into East Austin, given the changes demographically that were occurring overall. So then we looked across our system, and we looked to, and we did what's known as an organizational capacity assessment to better understand how are we using our infrastructure, our existing infrastructure. And so when we looked at Southeast Health and Wellness, it rose to the top, and we realized there was some capacity there. And if we built out some space, we could actually relocate that family practice residency program. And there's a domino effect. Some pieces are moving out, but the vast majority is moving into Southeast Health and Wellness. So the family residency program, Blackstock, will actually move into Southeast Health and Wellness mid-March. When we also took a look at unmet need, the zip code, Montopolis zip code 78741, actually, or 44 I should say, went ahead and actually hit as a high level of unmet need from a health center perspective. So we looked at federal data to go ahead and determine what number of individuals who are lower income have unmet needs that aren't being met by an existing health center here in Travis County. Us, Peoples, Lone Star, and is in the mix. And there's over 23,000 individuals who are lower resourced within that zip code that have unmet need, which is also almost 8,000 who are uninsured. And we already have a very large footprint there. The map that you're seeing off to the right is just a geographic distribution of unique patients served by Blackstock. And so we looked at that to say, okay, do we have a concentration around Blackstock? It's tough to see, but if I point to the slide behind the larger screen, our east, when we take a look at Blackstock, it's right about here, right? You can see the Colorado River of Texas coming through and Blackstock sitting there. When we look at this, there's really no concentration of population around Blackstock. Folks are coming in from across the Austin area. This is actually, when we take a look compared to our other sites, this is by far the most mobile population that we're seeing. We usually see pockets around each one of our sites. There still is quite a bit of dispersion comparative to what my past experience has been with community health centers. And Mike and I have talked, Mr. Giesel and I have talked about that a little bit before in terms of the dispersion. But here it's very evident. You can't really look at here and say we're drawing from East Austin, we're drawing from South Austin, North Austin. It's all literally all over the map, right? So when we did a dive into that, we really felt like Southeast Health and Wellness. Now we've alerted patients and worked with the faculty and staff and residents over at Southeast Health and Wellness in transition towards this. I'd be lying to you if I said there wasn't any anxiety about this type of a change. This is a long-standing practice, and of course, naturally there is. We've done our best to inform patients of the change and making sure that they're aware. And so hopefully that goes smoothly. We try to anticipate what we can anticipate, but we don't know what we don't know until we actually up and running. So we're committed to making sure that anyone who wants to follow their physician or their clinician down to Southeast Health and Wellness is able to. And if they choose to go elsewhere, then we'll facilitate either in our system or somewhere else. But we also think this is a great use of the resources moving forward, both in terms of the central health facility at Southeast Health and Wellness and bringing additional services to Southeast Travis County. So that's a wonderful facility. The new addition to Southeastern Health and Wellness that's also happening this month, thanks to some funding through the Health Resources and Services Administration through a health center infrastructure improvement grant from several years ago, is establishing walk-in clinic at Southeast Health and Wellness. So you may recall the back and the northeast corner, there's a conference room. If you've been through Southeast Health and Wellness, you've seen it draped recently. So there was five exam rooms.
There were six exam rooms.
Oh, Matt added one on me, so that's good. It's to the plus. So 6 exam rooms there. We're really pleased with their ability to do that, thanks to our partnership with Central Health. I think it's going to be a tremendous asset. The nice thing about moving walk-in clinic to this location, and we're moving it, the team is going to be an existing team we're picking up from William Cannon to come into this location. But the nice thing is we believe we're going to be able to we know that we're going to be able to provide on-site radiography. William Cannon doesn't have x-ray, so when you're doing walk-in, it's great to have access to x-ray, right? We're also looking at expanded lab services. There's a very large population already served at Southeast Health and Wellness and continuing to grow, especially as Blackstock moves in. So it's a great location for us to have our walk-in facilities. The grant provided to HRSA was initially intended for our Hancock facility. It was going to be expanded. Unfortunately, when we discussed with the owner at that site, they were not receptive to our use of federal funds at that site because it would have attached a federal interest in the property. And because of the value of the property, they wouldn't want to see a lien on the property from the federal government. Anytime there's federal funds that are used to build out space, the federal government has an interest and it actually has to be publicly noted in the records relative to the property. So we tried at that site for a while, and then with HRSA support, the Health Resources Service Administration, they allowed us to repurpose that fund to use at Southeast Health and Wellness. So we think it's a great access point for walk-in services, coupled with the fact that we had strong HRSA support. So that's mid-March as well. The next is really our William Cannon site, which we're converting to primary care, and that goes hand in hand with the walk-in. And so when we looked at this and we said, okay, what's the ripple effect? We have walk-in at Hancock, we'll have walk-in at Southeast Health and Wellness. We know there's significant unmet need in Dove Springs. And this is the first step in what we would see as another step in the Dove Springs area to increase services overall. The map you're seeing on the right-hand lower side is actually the top 10 zip codes in Travis County that have unmet needs based on federal data from 2017. And it really goes ahead and takes a look at. So these are the top 10. When we look at the zip code for Dove Springs 78744, you're seeing almost 16,000 plus low-income individuals currently not served by a health center. And we know that there are other providers that are serving. You've got pediatric providers and that are in there. The most notable, though, is when you look at the uninsured population where there are fewer accesses to resources. And when we look at that, it's almost 4,700 unique individuals who are uninsured residing in 78744 that actually need access to primary care services. And so it made sense for us to convert William Cannon to a primary care site. And in so doing that, we're actually picking up a part of our family medicine team that's being displaced out of Southeast Health and Wellness, bringing them to Dove Springs. That's the domino effect relative to Southeast Health and Wellness. So coming back to the very first slide, so the puzzle pieces that we're putting together really are about increasing access to services in the southern portion of the county and eastern portion of the county, not as far east as we're going to go with our partners here at Central Health, but we see this as a good first step in terms of realignment, using existing resources and changing the services that are coming out. Later this year, we have other projects that are going to come online that we draw your attention to. One of the ones that we're working with both with Larry. Oh, there he is. I was looking for you over there. With Mr. Wallace's support and facilitation is with Pflugerville ISD. That's another area. Looking at establishing a school-based health center there. Similarly, with Austin ISD is looking at Aikens High School, which is in South Austin, far South Austin. And then coupled to that is we're working with the Housing Authority here in East Austin as they're redeveloping property at Chalmers to go actually co-locate. For the very first time, we'll have some primary care, but not much. It's going to be connected to Sandra Joy Anderson, one nurse practitioner. But for the very first time in East Austin, we've never had dental services. So the plan is to actually add dental services. And so we're working very closely with our partners at the Housing Authority. And then later this year, sometime still as plans are being developed, and I'm sure Mike and Larry have kept you guys up to speed on this, is to actually go ahead and look at what we're going to do at an enterprise committee level relative to Della Valley, and then future plans as it relates to Austin's Colony, Hornsby Bend, because bringing it full circle to the Host Calls initiative that started last week, that was an important step, but it was a very, very small step to get to what we're trying to do in that community longer term. The one thing I think I missed in pointing out, and maybe it got dropped off on this slide, is mobile. It should have been on here. So we're targeting right now middle of May potentially for a mobile unit to Colony Park and Creedmoor. Do I have that right?
Yes, it's on there.
But, oh yeah, now I see.
M19.
Yeah, me.
M19.
I should know my own slides, right? There you go. So, anyways, so really more information update for you, but we know that you guys engage very much within the community, so wanted to bring to your attention some of these significant changes, acknowledge our partners here at Central Health. We can't do this without your partnership and supports, especially within facilities that are your assets, but also in the planning and with our partners at CCC. It's really a team effort. And then our staff, really, Matt's coordinating through his project management team, a lot of moves. Again, people don't like change. Healthcare is the same as everyone else, right? So change like this is always traumatic, and so really working through that process. So we expect a couple of hiccups, but I think we look back in 3-4 months, this is really going to be serving the community just that much better. And Yvonne and her team as well. No anxiety, right, Yvonne? None whatsoever. So happy to answer any questions you may have. Matt, I don't know if you had anything to add.
The only thing that I would add to that you touched on, Jason, was the increased access for South and Eastern Travis County that we're going to see with this. When we look at the existing family medicine practice at Southeast Health and Wellness Center, they've got the capacity currently to serve about 12,000, just over 12,000 patient visits a year. When we look at moving Blackstock into that space, we're going to be looking at over 20,000 visits of family medicine access a year. And then when we move the family medicine program out of Southeast into William Cannon, where it traditionally was a walk-in site, that's additional primary care access that we'll be seeing out of a location in 78744. So increasing primary care access, not only for 78741, but also 78744 in the southeastern part of Travis County.
Thanks, man.
All right, Jason, I'm going to take the first question.
Yeah, of course, Dr.
Because I already asked this once before. Are we going to do something to continue to honor Dr. Blackstock?
We are.
Okay, good.
Yeah, within the facility,
Yes.
that's our intention. Yes, we want to honor the legacy of Dr. Blackstock and the important contributions
You really,
made to the community.
care. You
Absolutely.
really did do fantastic work for our patients. Thank you.
I have something similar. You said that the Kosmetsky name was going away. Are we doing anything to honor the Kosmetskys, because they have been unbelievably generous?
So we're not, that's a relationship that it was established between Seton and the Kosmetsky family. And the name was actually, we repurposed and renamed it to something different based on their request.
On whose request?
The family's request.
Okay, then that
Manager
resolves
Greenberg.
that.
Yeah. Yeah, otherwise we would have,
Yeah.
we were fine with it
But
persisting.
if-
Yeah.
If the family was involved, that's all I.
Yeah, that's what
You're
we were advised by our peers at Seton.
Okay.
Yes, Manager Greenberg. Thank you.
Manager Perspective.
Thank you, Chair. Well, thank you, Jason and staff. I appreciate all of your work that you're doing. I have a few questions.
Yeah, of course.
The first one, we're talking about Blackstock Family Health Center relocating it. And I know that you said you'll be notifying patients. But in terms of access and transportation, and knowing that patients are used to going to that location, so is there a access, any kind of accommodations that you have to pick them up to the new location?
No, there's no special accommodations relative to, if patients have transportation needs any different than other folks going to Southeast Health and Wellness. So we do have for that location, there's actually an advantage to patients that are going through because there is a pilot right now with Lyft for folks who are coming out of eastern Travis County that are coming in. So when you do look at Blackstock, for example, pointed to Colony Park, you can see there's quite a few folks that are coming through. It's tough we can't count them off, but there's certainly at least 100+ patients that are coming from Austin's Colony. I said Colony Park, I meant Austin's Colony. There's folks coming from Colony Park as well, from Austin's Colony into Blackstock. And so there is the Lyft initiative that would help. But if someone happens to live in North Austin and they're coming down to Blackstock, then there's no specific way for us to help them right now, unless we do vouchers and other transportation, so we'll handle them as we do typically.
Possible within the, I don't know how we'll be informing the patients either by mail or phone to detail that access information on, in terms of what's available for the patients, because I know giving the majority are homeless, as you stated earlier.
That's actually at the care coordination clinic.
Oh, sorry, care coordination, I apologize, but.
There are some homeless patients at Blackstock, a couple hundred that have been served historically there, and so, yes,
I
please.
think that's really important, access to these facilities, giving the population that we are serving.
No, it's a great suggestion, and so we've got signage up at the clinic. There's both mailings as well as, there's mailings, right? Did we send out mailings?
Yes, we sent out mailings.
And then additional to that is electronic for those that have access to cell phones. We're doing a push electronically via text messaging, so we can add that to the text message, and so that we can indicate if you have transportation needs, please reach out.
And if I may add details to the mailings, given the dispersion that we saw in the patient population, we did include other access points. If you live north, here are some other options where we have providers who are accepting transfer patients as well. And so we detailed that information. We said if you live centrally or would be best served by a location centrally, here are your options. And then south, obviously, southeast Health and Wellness Center. So we tried to provide specific messaging for the populations that may be most impacted by this move.
Great.
Manager, so I think Sherry wanted to answer one of your questions.
No, it was just the Lyft. So the Lyft pilot is a pilot that Central Health is doing with Lyft and with the 211, using the 211 that we have with United Way. We have $15,000 that Central Health put towards this for the end of April. JP has been doing a great job, as well as other staff, in coordinating this and collecting data, and it's really taken off. So.
You know, it's wonderful, but I believe many patients are not well informed of that access.
Right, I was just giving more detail on that.
No, I appreciate that. I think, again, it's to the point of informing the patients, empowering them.
And Ron, just so that you're aware, that when patients are calling our patient navigation center, we do ask.
Yep.
And the other part would be is if they identify as having transportation needs, we assist as best we can.
And the same happens when they contact the 211 through United Way.
Well, that's wonderful and good information, whoever who's listening as well, to share it to others. In terms of the walk-in hours, what are your expectations?
So Monday through Saturday, 8 to 8 is where we're starting. Our Hancock runs 7 days a week. Eventually, I guess I'm on record, is we'll look at 7 days down at Southeast Health and Wellness. So Dr. Porter, if you're listening, you're charged with figuring that one out. He's our director for walk-in clinics. He's an ED doc by background.
And you mentioned something about reaching out to school-based clinics, and Manor ISD, and I know with the People's Community Clinic, they're expanding. Is there any discussions and talks that you're working with them?
As it relates to Manor?
Yes.
Well, we're aware of people's initiatives in Manor and very supportive of what they're doing in Manor. Our initiatives are focused on, with the AISD, Aikens, in partnership with them, we've identified that as a high school to go ahead and establish our first school-based health center with AISD, and then Pflugerville ISD. And then as it relates to people's, it might be helpful for the board to have them come in and give you an update in terms of what's going on in Maynard for them. Because their expansion, from what I understand, and it's not my place to relay, but theirs isn't just based on the school base. They're looking at an expansion in Maynard at large as well, in terms of supporting community needs at large as well.
There's many unmet needs in that area.
There's unmet needs for sure,
And
yes.
it's within our jurisdiction, and I'm sorry, I'm writing in in terms of, you talked about mobile clinics, and what's your plans with outreach and in terms of community outreach, once you launch these mobile clinics?
So I think, so for the mobile unit itself, that'll go to Creedmoor and to Colony Park. And Larry and your outreach, Ted's team, they're doing a bang-up job in partnership with our folks, and they've been hosting community outreach forums to both engage and gain feedback from community members about what the needs are. So Creedmoor, for example, is a relationship with the city of Creedmoor, and the ability to actually park the vehicle at their property at their community center. So we're going to rely on our partners to help get the word out, but I think we'll do a big splash come mid-May in terms of making a real push to make sure folks know that there's a new resource that's coming into their community, both in Creedmoor, Colony Park, draw attention to it. But really what we're going to rely on most is the folks who are engaged to help spread the word, right, to their neighbors and friends and family members. I think that's the most effective way for us to help get that out, but also use your assets in terms of social media and other things to get the word out that these resources are going to be available. Right now, the tentative plan is Tuesdays and Thursdays, 8 to 5 at Creedmoor, and that could change. And then Monday, Wednesday, Friday, right now, tentatively would be at Colony Park. And of course, this is subject to, timing relative to acquisition of the actual vehicle itself. It's, there's work that's being done on that right now. So that's a tentative date. I don't want to communicate that that's done by any means. There's still some things that need to be checked.
Okay, I'll have more and then I'll follow up with you. Thank you.
Yeah, please. Be happy to.
After all this.
Yeah, 3 minutes.
I know.
First of all, I want to thank you very much for bringing the Southeast Walk-in Clinic back. We knew it was always needed, so enough said. Larry, thank you for supporting Jason and doing that. With respect to the Del Valley and Austin Colony planning, I noticed the planning is up here in the December of 19, and I was just curious if there was something sooner that they might be seeing action on?
Yeah, it's not intended to be, it was meant to be just at the top. In 2019, it's ongoing. I know there's a line coming across. It's more of a placeholder just to make sure that I brought it up. There's a lot of discussion going on relative to that. I think you're aware that Central Health's working very closely on land options relative to Austin's Colony. Del Valley, there's conversations that are ongoing, both with Central Health, CCC, ourselves, School of Nursing. So I think that could advance quicker than December, but a lot of this is subject to very well-meaning folks in a room and things aligning properly. But we're hopeful that
I just didn't want to give the perception that they were last being served when they were here fighting for services.
Thank you.
And with respect to Dove Springs, now I know the city has already passed the initiative for bond for getting the Dove Springs Clinic.
The community center, yes.
The community center, but they're calling it the clinic. And so are y'all gonna be working with them and seeing how the services are gonna be divvied up or, and because primary care is at William Cannon, they did not have the x-ray machine, they did not have a prescription, pharmacy, and they didn't have anywhere to go. So that's, tying it to Southeast Health and Wellness Center, you're still gonna have people, you need to go to both places.
Correct. So if we expanded this beyond just 2019, you would see that we have Dove Springs as an expansion and increased footprint, and preferably and hopefully in partnership with the folks of the city of Austin. We've had some preliminary conversations, again, with Larry and others, and Stephanie Hayden.
Yes.
But they've just been preliminary. Nothing's been determined by any means. I think we buy in, as do our partners, many different partners, but collaborative partners with the city, that a one-stop shop makes a lot of sense if we can do it. The biggest thing will be is trying to figure out what can that facility accommodate, because we could probably consume quite a bit of the space if allowed to. So we're really looking forward to continuing those conversations with our partners and hopefully bringing a tremendous community resource to Dove Springs. So I'm looking forward to it.
Just one last ask.
Yeah, no, of course.
If you could tell us based on the plan, the alignment plan,
Yes.
if you could give us an idea or send us an update as to what services will be located at each of these particular clinics.
We'll
Okay.
definitely do that. Yeah, one of the things that we have that you're not seeing here, for example, is next month to our board, we're planning on, for example, our North Central site,
Right.
looking at adding pharmacy services on site, which we've never done before. And so those are some of the things to try to expand the existing services within our sites and then realize. So we can do that for sure.
I appreciate it, thank
Yeah,
you.
of course, thank you.
Any other questions? Shannon?
Just a quick comment, and that for someone who is sitting here, who would, looking at that, who has the geography, would look at that and say, wow, you're doing a great deal of capital investment or working in capital facilities in the south and east, south part of town particularly. Southeast Health and Wellness, William Cannon particularly, and you have something for Aiken, and it looks like you have planning for Pflugerville. Goes back to the question is, if I'm a resident of eastern Travis County, I see a mobile unit out there. Mobile sends a different message than a fixed location. So I think the question we need to be mindful of is that people out there will see the mobile unit and become very frustrated. I mean, very happy that it's out there, don't get me wrong. But why can't we have a facility soon? We've been talking about this for a while. I know Larry's working particularly with Colony Park, and it takes a while. But I just want to be mindful of the fact that even if there's a possibility of working with a school district out there, that we could provide services in, as you're doing in Aikens and maybe Pflugerville in the long term. So people have a fixed location that they'll be able to go into. I think that would go a long ways to public goodwill, particularly in that part of the county.
Thank you, Mr.
Yeah, no, well stated. So we certainly, our intent through the presentation this evening was not to communicate that these areas are being prioritized over the Austin's Colony, Del Valley. They're just not definitive plans as of yet, but those are being worked on. And moving forward, Manager Jones. So I do think, this is a repurposing of existing assets for the most part as well. But yes, I agree. We don't want to send the wrong message for sure.
Just one last thing quickly.
Yeah, of course.
Mobile units create not only a feeling of tendency, not immediate, long-term. So if you're going to do outreach, back to Member Maceta's comment, is that it needs to be really grassroots outreach. It can't be marketing. It's got to be in the community. When people hear about this and they show up, and one day the van's there, the next day they show up, it's not there. They get mixed messages. So I'm saying all of that feeds narrative in communities present. So I just want you to be mindful of those.
Yeah, no, very well stated. So thanks for that, Shannon. I really appreciate that feedback. We'll definitely take that into consideration.
Well, we're out of time. I'll respond to Manager Jones probably through the message board or an email to the board, but I think there's a salient point that Mr. Wallace had covered that I think directly answers your, is informative to the comments that you just made, but I'll do that offline.
Well, could you give like a one sentence instead of leaving maybe people
I
hanging?
realized, and I asked the chair to be recognized, and I remembered I heard the timer go off.
That's okay.
So
Maybe just one sentence so people aren't left hanging.
with respect to what Mr. Wallace laid out, this is about looking at all the different modalities. And yes, mobile clinics are seen as they are a mobile and are a temporary solution. But also there might be a more effective way to serve patients that doesn't involve a clinic footprint, maybe in the same size that we're talking about with Southeast Health and Wellness. There may be something that's a lot more efficacious. And that's going to change from one year to the next, or excuse me, from one period of time to the next as the population changes.
And that's because of population
And we
density?
want to be able to put a vision out there to say this is how we're going to care for the patient population and all the different means that we have at our disposal. That's what we aim to do with the work that, with the deliverables that Mr. Wallace has to do, so that people can see and know what to expect.
Okay.
I apologize if more than one sentence.
All right, thank you.
Thank you.
All right, Again, it's an informational item, no action is necessary. Agenda item 10, discuss and take appropriate action on the update regarding Sendero Health Plans, Inc., including the effects of federal legislative and regulatory activities.
We still need to do 9 unless you want to take 9 after 10.
I'm sorry?
You skipped 9.
Oh, I'm sorry, 9, I'm sorry, I apologize. I skipped. Agenda item 9, discuss and take appropriate action on the 1115 Medicaid waiver delivery system reform incentive payments, DSRIP projects, the Community Care Collaborative, including health care delivery arrangements and other interrelated community partnerships. Mr. Morgan and Mr. Canodal and Dr. Hernandez.
Good evening. I'm John Morgan, the CCC's Executive Director, joined by Dr. Mark Hernandez, our Chief Medical Officer and Executive Vice President. I would like to start by just directing your attention to the memo that was provided in your backup packet. I believe on page 128. It's a 4-page memo that serves as an update on the CCC's performance in the first year of the new DSRIP program as part of the 1115 Medicaid waiver. Somebody mentioned earlier tonight, time flies. I think it was, it seems like yesterday we were sitting here talking about what this new program was going to look like, and now the first year of the 4-year program is behind us. And the memo in your packet serves to update you on that first year of performance. As a reminder, our work at the CCC to improve the health of our population through participation in this program is part of the Central Health Strategic Plan, specifically objective number 2, which is to implement a patient-focused and coordinated healthcare delivery system. We'll keep our comments very brief tonight in hopes of leaving a little bit of time for questions, understanding that we're pretty late in the evening already. We're pleased to report, though, that through really the extraordinary efforts of our provider partners as well as our staff at the CCC, that when we complete reporting in April for the first year of DSRIP, we expect that we're able to report achievement on over 96% of our performance objectives related to the program. Our largest partner by far is Community Care. I'm glad they're here tonight and in the room. Not only are they the biggest DSRIP participant that we have, but they've also led the way in improvement in 2018. So we're very grateful to their efforts, and we're obviously in this together. And through Community Care's efforts, as well as our other partners, Lone Star Circle of Care and Hospice Austin, we're set up pretty well going into 2019 as well. Just as a reminder, the new DSRIP program really focuses on population health and health outcomes, quality metrics related to our patient population. It's a pretty drastic shift from the first DSRIP program that was infrastructure-based and project-based. This is really about moving the needle on outcomes. So there's a lot that goes into it. It's a very complex program. The rules kind of develop as you're in the program doing the work. So again, I want to recognize our staff and Community Care certainly being in the room. Just as another reminder, we spoke about this a year and a half ago at this point. The program for us is made up of 36 different clinical metrics that we selected based on our focus areas that include things like immunizations, cancer screenings, women's health, behavioral health, dental care, palliative care, and we are focused on measurable improvement to those measures over the course of the program. As I mentioned, we're off to a good start, but this program gets more and more difficult every year, and we have the added complexity that we're now in the second year of the program. In years 3 and 4, the work gets harder, and there's fewer dollars available in the program for us to draw against to support the work. So we're all buckling down for the next couple of years to try and achieve as much as we can. We're really proud of the progress so far, and we're happy to answer any questions about the program tonight.
All right, any questions? Ron?
Well, mine is more of a comment. Just want to thank you all for the work and efforts that you have done. Really much appreciated, and our community is thankful for the work that you do and your staff. Thank you.
Thank you.
Matt draw those.
Hi, thank you all for the presentation. I appreciate the work that you're doing. We all do, because you're affecting the health of our population. What I'd like to know, if there is any way that you all have looked at or could tell us how the results of the previous iterations of DSRIP have improved our healthcare system. You know, have those protocols been incorporated into the changes that are necessary to streamline those, how you address someone when they walk into your office and they've got all these needs that need to be addressed. How has the protocols changed? How successful have you been? That's why I'm assuming you have fewer dollars available now. And I understand you said that you had a problem, it was going to be most difficult to deal with this iteration as we're looking at outcomes, but the changes of the infrastructure is real important for me. And how are we serving more people, or I'm assuming, with fewer dollars?
And Mark, feel free to jump in, and I'll just make a few comments about the first round of DSRIP, and that it really was setting us up to a great extent to be successful in this round. I think one of the things that DSRIP has done for us and our community and our organization of providers all working together is it's really helped us focus on targets. You know, we've gotten in the habit now of establishing targets and then working towards those, and that's been a very good cultural shift for our community. Some of the specific programs in the first DSRIP, the first iteration, the first 5 years, were specifically building infrastructure that help us in this current state. Some of that was developing disease management registries, developing chronic care models for how we care for our patients, taking all of our primary care providers through the patient-centered medical home recognition process, and getting all of those individual clinics recognized was no small lift. And I think it's part of what you're talking about with it, which is, you know, how do we become patient-focused? How do we organize our resources around our individual patient needs? And, you know, it's developing those processes in DSRIP 1 that really set us up well going into this new program that's about outcomes.
Is there a way to tie numbers to them? Still to the issue of we had so many on the rolls waiting for services. Hopefully do we still have any of those original members from those first numbers that were given or provided to us? How are we doing and with what we originally had for, I'm assuming, a baseline to where we are now?
So the challenge in answering your question, Cynthia, is the breadth of it. So it is a great question, but the breadth of it challenges our ability to answer it immediately, and we can certainly talk to it. For example, we could talk about a specific previous project in the last DSRIP program, for example, pulmonary clinic. So we could talk about the fact that this was the amount of that service that existed prior to that DSRIP project coming online. This was access after we put that project online. This is how many additional patients got cared for. This is what the state of that line is. We can talk about that. Because there wasn't a specific DSRIP project that looked at joint disease, during the early parts of DSRIP, the waiting line for musculoskeletal care remained long. And the DSRIP project didn't do anything directly. The whole of the 1115 waiver program didn't do anything to help that because, frankly, CMS had turned down our DSRIP project in musculoskeletal care. It wasn't an approved project. We didn't fix that problem until we entered into our collaboration with the medical school, which was separate than DSRIP, but came into play and helped us resolve that problem. So the breadth of your question touches on every single kind of piece, and some of those pieces were affected by DSRIP, and we can definitely come back and talk to you as a board or individually about what were the positive effects of DSRIP, first version, that 6-year piece of work, and what things didn't change. I think, and hopefully my colleague back here, Jason, will nod in the right direction, but I'm not going to turn around. I'm just going to hope that he backs me up here.
we take care of more patients today than we did when this whole thing started, and he wasn't here when this whole thing started. But, you know, we have seen nothing but an increase in the number of patients served over all of the years that I've been associated with the system, and certainly Jason's experience has been that the numbers keep growing. We expect that this next year will be bigger than last year in terms of the numbers of people served. I choose to believe that part of that is because we went into a deliberate period of infrastructure building. But that isn't the only reason. Part of the driver is people keep moving to Travis County. There are just more people that need service, and they keep coming into the clinics and coming into healthcare. And so whether we built the infrastructure or not, we were going to see an increase in. So I think for me, I kind of align with the way this second 1115 waiver is set up, which is to say, if you did your work right and you set up infrastructure through the projects that you did in the first 1115 waiver, and you were successful in those, which we were, and you drew down additional funds, which we did, and you invested those additional funds well, which I hope we did, you should be able to demonstrate improved clinical outcomes in this next DSRIP, because now we're going to quit testing you on whether or not you built infrastructure, and we're just going to test whether or not you actually make people healthier. That's what we have to do right now. We were successful in this first year of this DSRIP project in showing that we have created health in those areas in which this 1115 waiver project is settled. Do I think that tells the whole story? No, and let me just give one quick example and then I'll get out of it because I know Pete needs us to keep moving along. In the first 1115 waiver, we put an emphasis on the notion of we needed to do tobacco cessation. We need to ask patients whether or not screening, do you use tobacco in any form? And then if you did, and you answered yes to that question, yes, I use tobacco in some form, did we document that we counseled them about tobacco use? And that was an crucially important thing, and we weren't super good as a system in that when we first started in the first waiver project. But now, every one of our providers is routinely over 90% in that bucket, and in fact, I'm cheating them, it's usually over 95% in that bucket. In terms of, do we ask patients if they use tobacco? We always do. Do we actually do cessation counseling afterwards? Yes, we do. And that doesn't matter unless some of those people stop smoking. Like at some point we have to quit looking at the thing that we've gotten really good at, because that thing doesn't actually create health. If we want to demonstrate we've created health in that population, we're going to have to figure out whether that effort has actually led to a decrease in the use of tobacco, because that's the thing that creates health, not me asking you the question. And so as we pivot into this new 1115 waiver project, we need to get sharper, and they're helping us because they're pointing at us and saying, get sharper. We're going to have to get sharper about worrying about the things that matter. And the things that matter is, did we create health in this population? By the way, it's what we should be paying for. So I, with interest, heard you are going to be talking about healthcare contracting at some point. I think it's May. What I would emphasize in that is good healthcare contracts don't pay for healthcare, they pay for health outcomes. That's where we need to move the system. We should be paying for things that matter. I'll shut up then.
Thank you.
Mr. Giesel.
Actually, we were going to ask you to talk about those contracts.
As long as I can bring them along.
Haven't got the memo right yet. Thank you.
Any other questions? Seeing none, Rob.
I just want to echo what you just said, paying for what matters. And I think hopefully all health leaders can grind that notion.
It's hard because we haven't done that ever, really.
But we have an opportunity here.
But we should.
Thank you.
It's our mission.
Mr. Morgan, Dr. Hernandez, thank you for coming.
Thank you all for having us.
All right. Now we're going to take agenda item 10. Sorry about that, folks. Discuss and take appropriate action on update.
I'm so sorry, but we have one more presentation.
Oh, sorry. Sorry, Jeff. I saw your name here. I thought. Sorry, Jeff.
Well, that's all right, I can understand. 8 o'clock and talking about financing. Thank you.
Always a pleasure here for you, Jeff. You know that.
Sure. Well, I brought Monica Crowley here as well, so that makes it much more palatable and entertaining. So we are here tonight to begin talking about a couple of things that are on the horizon. This will not be the last conversation. This is really just a information presentation, and we'll be having more discussions, particularly as we progress along through the budget process. But we wanted to start talking about two things related around the 1115 waiver. The first is related around some changes that are coming up in uncompensated care. And the second item is the formation of what we call an LPPF, which is a local provider participation fund. So I'm going to kick the presentation off and then turn it over to Monica to talk a little bit about LPPFs. So real quickly, just to start the presentation to kind of set an anchor for some of the upcoming discussion. On the 1115 waiver, the waiver consists of two parts, and you just heard the part about Deseret, which again is 4 years of funding, and I think I heard a reference to some reductions in funding. So as it relates to Deseret, there are 4 years of funding. Year 3, which would be known as demonstration year 9, and we won't get into all the years, has a 6% reduction, and then the final year of the 4-year period has a 20% reduction as it relates to valuation. There is a reporting period and a payment period. These are not advanced grants or block grants. These are you get paid for achieving outcomes. So we do have somewhat of a lag even on the payment process. So the payment process can actually spill over to 2022 and quite frankly even 2023 with carry forwards. The other significant or portion of the 1115 waiver is around uncompensated care, and in the 1115 waiver that was approved, there's 5 years of funding related to uncompensated care. We're in year number 2 of that 5-year period, and funding for uncompensated care is a fixed amount at $3.1 billion across the state. I'll say right off the bat that we have much more uncompensated care across the state. Occasionally when we talk about uncompensated care, we talk about significant haircuts. That's what that's about, which is much more uncompensated care being incurred by hospitals than funding exists across the state. As I mentioned, we're in the first full 2 years of funding at $3.1 billion. Subsequent years, or years 3 through 5, the amount of funding is to be determined. So we don't know at this time what the exact amount of funding is going to be. But we do know beginning next year that there's a rule change regarding the distribution of how uncompensated care will work, and we'll go through that in a few minutes, but it mainly relates to how the payments are distributed for uncompensated care as kind of a preview. And again, that's going to start next year in demonstration year 9 or October 1 of 2019. So that for us, that's fiscal year 20. So as it relates to some of the rule changes, here are 3 elements. These are really, there is a whole lot of detailed regs related around this. Hopefully we've boiled down the 3 main issues related around the changes. The first change, and this is a real important element, previously there was a direct relationship in uncompensated care between the local share, which draws the federal match, and then where that goes to. So that relationship was more of a, what was called a directed IEP. So we would have a certain amount of local funds that we call IGT. That amount would be sent to the federal government, and it would be designated for a certain facility, a certain hospital. The local and the federal amount would flow directly to that facility. That's changing beginning in 2019. And to the second bullet point, that distribution will actually be made through a pooling process. So there will be a pool in the, so the local funds will be pooled and they will be distributed amongst all facilities, all eligible hospital facilities in the Medicaid delivery, in the Medicaid service delivery area, what's called the SDA. So this is significantly different than what we've seen in the past. There will not be a directed intergovernmental transfer, or the local funds will not be directed to specific facilities. And then the third bullet point is just as it relates to the calculation of the uncompensated care caps. In the past, it's consisted of a few elements, and primarily the calculation will be limited to hospitals' charity care policies. So just a quick map, when we say distributed across SDAs, Medicaid service delivery areas, what does that really mean? So in Texas, I think it's fair to say that there are several SDAs. There's one really large one in West Texas. There are a number of SDAs on the eastern side of Texas. Our SDA is in purple. You see there in Travis, it will consist of 8 counties. It actually consists of the 6 counties in RHP 7, plus Williamson, and plus Burnett County. So 8 counties total.
Was that?
I'm sorry?
Are those additions?
Well, it's the SDA. The SDA are the 6 counties in RHP 7, which are really just the surrounding counties, plus Williamson and Burnett. So my apologies in advance of boxes and arrows, but hopefully this helps a little bit to illustrate some of the funding flows. And then as we talk about the LPPS, we'll build on this graph. So this is kind of a starting point to look at the funding flows for uncompensated care for both how it exists today and then how we see it existing beginning next year. So on the top row where it says demonstration year 8 or fiscal year 2019, that's how uncompensated care works today. And as I spoke to earlier, the local funds are sent from an IGT entity. Federal funds are matched, and then they flow to a specific hospital, or they're directed to a specific hospital. So if we were going to send local funds to Del Seaton, for example, we would send a specific amount. There's a specific match amount that would be added on the federal side, and that local plus the federal funding would be sent specifically to Del Seaton. So beginning next year, it's going to work a little bit differently. And so I've tried to illustrate that on the bottom part of this graph. So there'll be multiple IGT entities that will provide the local share that will be matched with federal funds. So those local funds will be pooled, so to speak. That pool will draw federal funds from the federal government, and then it will flow to hospital facilities all across the SDA, or the 8-county region, based on the amount of uncompensated care costs that they incurred for that year. So it's a lot different than directing intergovernmental transfer. So in essence, there will be IGT local funds that would be pooled across an 8-county area that will be sent up for federal match and then distributed again across the service delivery area, the Medicaid service delivery area. And hospitals will again receive both local and federal funds based on their uncompensated care costs.
And it's not proportionate to how much the IGT entity sent up, and it's not directed or related to any way to how much your IGT, entity from your county sends up. It's
right.
Split across
It
the
is,
SDA.
if $10 was all that was sent, and that's an extreme example, that $10 would be distributed to all the facilities across the SDA, regardless. Now there is a big, there is.
I want to think about that one again.
Okay.
Can I ask one quick clarifying question?
Sure.
To all the hospitals based on their uncompensated care, right? Isn't that what you said?
Yes.
It's not equally. So
That's right.
there's some,
It's
if I'm understanding this correctly, there could be some redistributive aspect to this, right? That you could have a hospital that sends up proportionally less, but gets, quote, more back based on the amount of uncompensated care it has. Is that correct?
Yes.
Yes.
Based on whatever their charity care policy is?
Based on their uncompensated care.
Okay.
Right. Now there is a, risk in this. Remember, one of the basic premises of providing a local share for intergovernmental transfers, you're not required to IGT.
Right.
You're not required to do that. So regardless if an IGT entity sends in the IGT, it still gets distributed across the service
So I'm
delivery
saying there's
area.
could be a redistributive aspect to this.
So it's really more of really think of it more as a pooling process. So this is a lot different, and we'll certainly have subsequent discussions about this, and we'll kind of build off of this as we talk about LPPFs. But I'll turn it over to Monica to have that discussion.
So one of the ways that some of the other counties with some of the hospital districts so far, Dallas County and Tarrant counties, one of the ways that they're looking to address this change is through these local provider participation funds. And what a local provider participation fund is, it is sometimes referred to as a provider tax, and all of these local provider LPPFs must comply with federal healthcare and tax regulations. In Texas, they're more commonly referred to as levies or assessments, so that they can make it through the Texas legislature, because you have to have legislative action to create an LPPF in a city, county, or a hospital district. In an LPPF, all of the private hospitals in the defined area, which here it would be, within Travis County, pay into the provider fund, and then those funds that are paid in are used to provide the local share of the IGT. So the private hospitals are contributing in, no taxpayer dollars are contributed into that. And then because you have a public entity like a hospital district, or in areas that don't have hospital districts, you can have the county or a city administrate it. You have a public entity that is levying the assessment on the private hospitals, administering the fund, and then sending up that it becomes the public funds that are the local share of the IGT instead of tax dollars.
Can I just ask for clarification?
Go ahead.
What is the definition of private hospital?
Private hospitals are hospitals that are, and this is a federal definition that's defined in the tax regulations. A private hospital is any hospital that is not owned and operated by a public entity.
So UT and A&M are public hospitals, they're not private?
Yes, those are state-owned hospitals.
Baylor, Seton.
In Travis County, all of the hospitals in Travis County under the federal rules are private.
Except.
All of them are private.
Yeah.
Because we don't own or operate.
Right.
We don't have a public entity
So-
that owns or operates.
Clarification, if I may.
UT doesn't own a hospital.
No, it's the Seton, that's what I was gonna say.
Seton does.
Seton, yeah, that's what I was, I thought that's where we were going with. Seton owns the hospital, not UT. But this is, if I may, a little different than what we typically think of the definition of private, Cynthia, and I think this is what you're getting at, because in this definition, nonprofit hospitals fall under private. What they're saying is anything that is not owned by the public sector, right? Meaning a state or city or county, right? So anything that's not owned by the public sector in this definition is private.
Yes.
Okay, I'm still trying to wrap my head around this, because when the board for the University of Texas system, maybe you can clarify this for me, do they not own the medical school?
They own the medical school, but they don't own
the hospital.
Del Seton Medical
That's
Center
Del
at the
Seton
University of
Hospital
Texas.
on their property.
Yes.
Yeah.
Yeah.
Right.
They own the land under it.
Right.
Yes.
Got it, now I got it.
Yeah,
Okay.
yeah. So, and they lease the land under it to us, but that's still, for these purposes, it's the hospital license and the hospital facility. It's owned and operated. And so so looking at the next slide, so the current is still, what Jeff described before, it's directed. With an LPPF, you have all of the private hospitals contribute into the administrator levies the assessment on the private hospitals. They contribute, and then in the counties with public hospitals in Dallas and Tarrant, and I think Amarillo also has one, the public hospitals contribute up into the federal funds for the public hospital. So they send up the local share, and then they all get pooled and distributed. But because all of the private hospitals have to contribute into the LPPF, there's really no harm to it, to the taxpayers or the public entity, because the private hospitals are contributing their share of the local share into the LPPF.
And that's usually how that's assessed is a percentage of net patient revenues. Is generally how that's calculated.
And then we've got, right now, we had mentioned before, Dallas, Tarrant, and Amarillo are areas that have LPPFs and that also have hospital districts. And then there are other LPPFs along the border. There are LPPFs in Williamson County and Hayes County, in our kind of general area. And then there are other LPPFs kind of just spread throughout Central Texas and then in East Texas.
I think that's why I was asking about Williamson County and Burnett, because I thought they were in a different region, so this is different from the region.
It's different from the RHP. It's
Yes.
the same
Got it.
region
Same.
for Sendero for the insurance
Right.
plans.
Yes.
And there's more to it. I think there is going to be legislation filed in Travis County for an LPPF, I think in probably tomorrow.
Have a number?
Not till it's filed.
Not till it's filed.
You get a number till it's filed.
And Senator Watson will be filing it?
Yes,
can
and
talk
so
about that
there's a lot more
strategically.
detail that will come as the legislations moves filed, yes.
So
Yes, ma'am.
this is really dense information, and I think before she even moves forward, I have a few questions. Is it possible?
Go ahead.
Oh, well, this is it.
Oh, that's it? Okay,
Yeah.
perfect timing.
Yeah, I was gonna say.
We're gonna try to, as we
Yeah,
evolve
we're
over the
trying to-
budget, we're gonna try to do bite-sized
Yes.
pieces of this, and then hopefully keep you abreast of it as developments occur.
Well, I appreciate it. Thank you. This is new for us, and I wish I had learned about this before I heard it from the public. So I was in a meeting recently, and this came up, and I pretended that I knew what it was, but I did not at that moment. So I'm asking in the future if there's such drastic changes happening, especially to models, that you inform us in a timely manner before we hear it from the public. Just, it wasn't very, I know whoever decision making it, it was a very awkward position that I was in. So giving that, now if this whole model LPPF works, so the private hospitals will put in money. And that will, for us, that will be Seton.
That's all of the hospitals in the county would have to, all of the private hospitals would have to contribute, so that would include the large hospital providers like Seton, St. David's, and Baylor Scott and White that have hospitals in Travis County. But there are also small hospitals, like the Lakes and small private hospitals.
So what would happen, so we will not send any tax dollars up, correct? We will no longer send tax dollars up to the federal government.
There are different permutations of the model, so if in the other counties, the way it's been passed, it's only covered uncompensated care and things like the Europe program, which is an enhanced Medicaid payment program. However, in the other counties, it doesn't cover DISH, and so they're still transferring for DISH. There's nothing that would preclude Central Health from providing some of the local share for some uncompensated care if there was a reason for us to do that. And then Central Health, of course, would still transfer for DSRIP.
And DSRIP is short-lived as well.
Yes.
I know this was presented, I believe, probably last or before legislative session prior, and it did not pass. There was a bill.
Travis County's never tried to present an LPPF
Well, another
bill
LPPF
before.
was submitted, and it did not pass, and it was.
For another county?
It was another
Is that what
county.
you're
It was somewhere, I believe, but it was filed at the Texas legislative session.
Yeah.
So the reasoning behind it.
About that. Yeah, I'm
we're
sorry,
not
we're not aware of that.
Oh, I can send you the document. There's some notes.
There must have been one that had some trouble and then was amended to.
So what was the trouble behind?
But it would have been another jurisdiction.
Right, not us.
Right.
Could it be due to the proposed taxes?
I don't.
Yeah, we don't
We
know.
don't really,
Yeah.
I don't, I mean, we'll be happy to look into it.
Absolutely.
I think it will be helpful for us to see why and how we can improve it. And hopefully down the road, if you can also, at least a one-pager outlining the value that will bring if we move forward with this LPF model. And knowing that we're also waiting on legislative approval, and if it passes, hopefully it will. If it does not, what's plan B as well, if we have any?
Well, I would
Was
offer, I would offer it up a little bit different. There's nothing that precludes us from not making any changes. on the, as far as the funds that Central Health could provide. This provides us flexibility. This is just because we're presenting this tonight doesn't mean that we're going from some proposed legislation to this becomes our model of funding in fiscal year 20. So we're just trying to keep you up to speed on what the models are, what some of the legislation is that we're proposing to be filed. And we still have a number of months to work through what our funding model looks like beginning in fiscal year 20. So I don't want anyone to come to the conclusion tonight that because this is being proposed that this is the model that we're moving to. This is an option that we're proposing at this time. And we will look over our budget process at what options we think are best for Central Health and providing the funding to provide the care for our community.
That's helpful, thank you.
Although that is absolutely the case, although I want to be clarify that the changes in the uncompensated care rules are published changes that will go into effect October 1st, 2019. That is done.
And you mean in the Federal Register?
Yeah, in the Texas,
in the distribution,
yes,
the pooling,
that's gonna happen.
that is for certain.
Yes.
So sorry I wasn't clear. It's the LPPF piece.
Right, absolutely.
That I was referring to.
We have 3 more minutes. Any more questions? Yeah, this is an informational item, no action is required.
Thank you.
Thank you all. Agenda item 10, discuss and take appropriate action on an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. Mr. Giesman.
Yes. Members, this will be brief. 2 items. One relates to the number of non-Travis County residents that are insured through Sendero. Informed by Sendero Management, this is approximately 35% of membership, which based on a 12,000 effectuating number for this year is about 4,300 individuals. The second item is actually pertains to the presentation that was given to the county earlier this week. I'd asked to be able to close on the item before the court, but I think just because we started running over some allotted times and the court needed to move on to the next agenda item, there was a salient point that was not made. And that was the following. Even though the activity of contacting MAP members and asking them if they wanted to transition to Sendero Ideal Care was very successful by any measure. And yes, if all the scenarios play out, Sendero could be at a slight profit or break even. It is still early yet, and we're not out of the woods by any stretch of the imagination. And that goes for 19, but also in the out years, 20, 21, and 22. So there's a cautionary note here, but I think that's an important point to know. We've just simply executed on the first phase of the business plan for 2019. There's still a lot more projections to come. We still need to come back and report to this board on the viability of the business plan as well. We understand that. But anyway, that's all I needed to clarify, and I appreciate the board's attention to this.
Sure.
So I have one quick question. I certainly understand what you said about the business plan, and it remains to be seen if the projections come true and break even, and then in the following years too, and we'll be dealing with that, I'm sure, in our budget discussions. But it was the first item. That was important. I'm glad you made the statement to clarify, because since you weren't able to close, just so the public understands too.
Yes.
But on your first item, this is something that I asked for the information, and I'm glad that it has been reported, and that is that 35% of those who are being served by Sendero are not in Travis County. Is that correct?
35% of the membership.
Of the membership.
Yes.
And so my question is, what is being done, and this was the other part of my question, and asking for this data, what is being done in those counties to contribute to the livelihood of Sendero.
Aside from paying the premiums?
Yes, because we have been contributing all of that, but we're hearing that 35% of those people, in fact, are not Travis County residents.
Right.
But our taxpayers have contributed the full freight.
So the specific question that you raised is what's being done in those counties. If it's referencing another entity like the county government or
no.
a healthcare district.
Is there anything being done so that they will contribute what should be their share?
Not specifically with the county, but we are collecting premiums from those individuals.
No, I understand that. I understand we're collecting premiums, but this is a separate issue because here in Travis County, we're collecting premiums from our residents, but we have also put in a lot of money here from Central Health that is only from Travis County taxpayers, but 35% of those people live in other counties, and their taxpayers have not contributed.
There's not another contribution effort similar to what you see here in Travis County for those outlying counties that are in Sendero's service area.
Okay, I would ask that this be an item for future discussion because that was the other part of my question was what was going to be the plan regarding
And I'm
that.
simply just reporting on the number. And in
Right.
addition to that, Manager Greenberg, there's still additional analysis to be done to be able to show, okay, relative to the premiums that are being paid and what the capital contribution is from Central Health, how does all that net out? And that's an additional calculation that we owe you as well.
Right,
And that's part of what you asked for.
That's what I'm asking. Yeah, exactly.
Okay.
Thank you.
Manager Jones?
Just quickly, I piggyback off of what you said, 100% on the 35%.
Yes.
That's a burden the taxpayers in Travis County
Right.
are contributing to this effort, regardless of, the other counties are not.
Right.
So that's an equity issue there.
Exactly.
But the first question was related to, I don't want it to be said that even though Sendero has turned the corner, has made some progress, that the belief is that those expectations that we set last year are not there. My concern, I'm hearing I keep hearing that we did better. We made some progress. That's the word I said. But I thought I was at least very clear that our expectation was by next budget season that we would have turned this around to such a level that we're confident that they'll be able to take care of and to be successful. And here we are 7 months into the year, and I'm just hearing things, well, we're making some progress. So I guess I'm a little uncomfortable. I'm sorry?
The calendar year begins January 1st.
Yeah, well, I mean, from the period of time in which we originally had the discussion, the expectation was that by February, that they would report back to us that significant progress was being made, and I'm not hearing that.
That's
I'd
correct.
like to know what item that we're discussing this under, okay? Because
Sendero.
the Sendero is not here to respond to any of our concerns. I'd like to know which item it is.
So Sendero
Holly.
is item number 10.
And I'm looking at it, it says,
And Central
an
Health-
update regarding Sendero health plans, including the effect of federal legislative and regulatory actions. And the reason I'm asking that is because if we have questions, I would want the Sendero team to be here to respond to them.
Well, this is not related to Sendero. This is
It says
ours.
Sendero.
Yeah, but this is an issue that we presented at the motion that we took
I'd like to
on
call a
9/22.
clarification from Holly, so I can ask.
Hold on, let Mr. Gislin answer.
Well, counsel, I guess.
So we do not need to have Sendero present to discuss items that Central Health has authority over. And so my understanding of your question, Manager Jones, is do we have enough information for this fiscal year 2020 to decide if we want to contribute and we as Central Health risk-based capital again to Sendero?
Not so much do we have enough, do we have enough information? Yes. Because what I'm hearing over and over again, since our initial discussion of this, that we would be beginning to turn the corner or seeing progress. And what I'm hearing is that we're making little progress, but that's not why I voted to support this effort. I was under the impression there would be significant progress in terms of moving down the line. And now I'm hearing, no, that's not what we said. That troubles me.
Well, I understand, and I'm restate, just to make sure that I'm being clear. What we've done is we've executed on the first phase of a business plan to be able to move MAP members over to Sendero Ideal Care. So to answer your question of, is 19 shored up, and do we know that at a confidence level of 100%? And the answer is 2 months into the year, no sir, we don't. And that's why in the board's motion, you all said no later than June. And we're going to drive towards that June date to be able to have as absolute an answer as we can get for you, or as best a projection as we can get for you. But we're not trying to frustrate the board's analysis of this situation. We're bringing you all the information that we have as soon as we have it. But I don't think that there was any expectation that we would be able to start running projections. Right now, the best we could do is give you a hypothetical on 19, but actually start running projections this early in the year.
No, and that's not what I'm asking. I'm just asking because there's data and then there's expectations. And the expectations I'm hearing seems to be less than what the expectations were at the beginning of the discussion. As opposed to saying, yes, we're making progress, I'm hearing, well, we're being somewhat successful, we're making a little progress. That makes me a little unnervous, is what I'm saying. So as these next 4 months that we get into this, my expectation is that we're going to really be able to make be able to see some progress as opposed to just say we're making little progress, because that's not the sense I had when I voted to extend this, and that's troubling to me.
I think if you were under the impression that there would be a strong financial I shouldn't say strong, but a full financial projection for 19 in February this month. I think that's why the board chose in that motion that was adopted in September to push that out until June. And so while the choice of words that I'm using I realize may not be comforting, at the same time I feel like I need to inform the board to say, here's what's happening. And we don't know what we don't know. So I'm trying to be as upfront as I can. And I realize it may not be comforting, but
No, maybe I would ask if we could go back and get the minutes from those meetings and just review, not now, but at a future meeting, discuss this, because I'm hearing a different tone. Maybe that's the word I'm looking for.
And I'm being very conservative about it too. And you'll probably hear a different tone from Sendero Management, for instance, as well. But I'm reporting to you in my capacity. This is what I know today, and if the
but technically,
I'm not sure what else to say.
Technically, if we use that same analogy, this is what we know today. When we voted, I would have said probably no. What I heard was that this is what we know, but we know that within this time frame we'll see a turnaround and moving forward. What I'm hearing now is this is what we know. It's not that rosy, but it may be. Those are two different interpretations.
You're right. You're absolutely right.
And that's disturbing, because if that's the case, I think that what I was led to believe at the beginning of the discussion was not completely accurate, and that's what's I guess disturbing to me.
I understand. But the situation is what it is, and I got to call it like I see it.
No, I understand. I'm not saying you're not. I'm just saying is that when I look back over this, what has it been? 5 months or so since when we first talked about what we wanted to do and what plans we were going to have in place and some strategies. I'm not seeing that that's coming forward. So,
well, sir, actually, in fairness to the Central Health and the Sendero staff, they executed and did everything that we represented that they were going to do, and did so with a highly effective closure rate. And really, and I got to give the credit to the Sendero team for being able to make those closures. And so we did execute as we said we would do on this first phase. I just think the financial results haven't firmed up enough so that we can present to you something that says, okay, we're 80% confident this is the way 19 is going to turn out.
Okay, well, we have a few months to see.
Yes, sir.
Yeah, that's right.
Got 5 minutes. Cynthia.
One of the things that we were told is that it took them eligibility a long time to set up the process, to make the phone calls, to do this, to do that. There were lots of significant barriers for them to finally start recruiting people or talking to them and letting them know what their options were, establishment of the process, and it was a much shorter time period. Remember, this enrollment period was very short, and they didn't have this process down according to what I remember us being told and an update until almost the end of, I don't know, October? November had already started, and they were still working on tweaking the process, is what I was led to believe.
No, ma'am.
And, no, I'm just asking, that's what I remember understanding, that there had been some different things tried and done, and if you recall, at the last meeting, I asked when we were gonna have a discussion to look at actually what happened, and I was told that as they're still awaiting the numbers, because they still don't even know what their enrollment is, they haven't been provided that information, or how many people have actually enrolled.
Effectuated.
That's right. So as soon as they get that information, you know, then we'll have a better idea and a discussion that I would hope that we could have to talk about how that process laid out, okay? Because this is our opportunity to evaluate what we were told, whether it actually happened the way we assumed or were told it was going to happen, and whether or not the validity or whether or not it should continue for another iteration, another program or not.
I clearly said, I don't want to be here next year
That's
having
right.
the same discussion.
That's right. And that's why
here we are about to go into the budget season in April, talking about, well, we're still not sure the numbers and certain.
No, that's not our problem. We have to get that from the feds.
No,
The feds
No,
confer.
no, he's not talking about the feds.
No, but according to the resolution that we adopted, we were told they were gonna do a preliminary accounting or update to the County Commissioners Court. We were gonna get an update from them in June, and that was all. Remember, y'all participated in writing out that resolution that was that motion that was adopted. So there are very specific things in there that I think that
we're supposed to show progress was being made.
So just a reminder, we are over our 10 minutes. And traditionally, how we would resolve that is we would make a motion to suspend our rule. And that would require a motion to suspend the rules and a 2/3 vote. It's up to the chair if he wants to continue the discussion, but we did set a 10-minute limit.
I would just like to suggest that maybe if we can get a copy of that motion and the action and send it to all of us so that we can have that for the next time we're going to discuss this.
Along with the copy of the minutes of that meeting.
Well, that's right, yeah, because it would show that it passed.
Vice Chair, do you have one last thing?
Given that the time has lapsed, I think that we'll be continuing this during our budget discussion, and we will have to see what actual numbers we're getting then, as far as not just how many people, the staff did a great job in enrolling, Chad, how many effectuated and paid, but we then have to look at the claims and everything else, and in June see where we are, and then there's the future years. And I think getting the minutes and resolution will be helpful, as well as, of course, the information that I asked for earlier on this taxpayer equity issue.
Understood.
Thank you, Vice Chair. All right, let's go to agenda item 11. The next Central Health Board of Managers meeting is scheduled on March 27, 2019 at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. All right, do I hear a motion for adjournment?
Move adjournment.
All in favor, say aye.
Aye.
Thank you, members.
Can I make a point?
Sure, we're adjourned if
We
you can
didn't
make a
ask for
point.
the discussion, so that's why I was waiting for you, any discussions, maybe you didn't.
On the adjournment?
Yes.
We're adjourned.
We're adjourned.
You want
Well,
to,
I believe all items should not be equally weighed.
Well, we're
and
not-
given-
We're not
That's
meeting
what I said.
anymore. You all can have a discussion,
Well, I
but we're
just
adjourned.
wanted to.
That's what I had said.
what did you want to discuss, Maron? On